afternoon, sir.
Good afternoon. Good of you, huh?
You are in Calcutta?
I'm in Calcutta. Okay. How to make it view bigger? Okay. Hi, Manisha. Just eating a lot of fish.
Hi, Kalpana.
Hi, Manisha. Hi, sir. How are you?
So mine will be the recorded speech. I will not give the speech. Okay. But question answers, if at all, I will be there.
Sure, sir. Hello, sir.
Hi, Rima.
Hi, Rima.
Hi, Kalpana. Hi, Manisha.
Hi.
Hi.
Hello, sir. How are you?
Thank you.
Rima is growing younger by younger.
I know. Each time I see her, I feel, oh God, when am I going to become that?
How's everything?
Going on. Busy now.
Rima, put off your virtual background. It's not working well.
Yeah, it's reflecting quite a bit.
Yeah.
Yeah. Okay. Do I go back to the setting all over?
No, just stop video जहाँ पे है उसके पास जो arrow है उसमें आ जाएगा.
आप पीसी यूज कर रहे हैं, लैपटॉप यूज कर रहे हैं मैम? एप्पल का लैपटॉप यूज कर रहे हैं मैम?
Laptop.
एप्पल का मैम?
Yeah. Choose virtual background. Okay.
मैम अभी आप कौन सा लैपटॉप यूज कर रहे हैं?
Mac.
एप्पल का? मैक? हाँ, मैक पे मैम वर्चुअल बैकग्राउंड वर्क नहीं करेगा विदाउट ग्रीन बैकग्राउंड मैम.
Is it okay now?
यस मैम, इट्स नाउ ओके.
मैंने हटा दिया. Is it okay?
यस मैम.
Okay.
Hi everyone.
Manisha, 4 to 5:30 and 5:30 to 7. Is
Yes.
it not?
Yes, sir.
Session 1 and session 2.
Hi Manisha. Hi Kalpana, Rima. Hi Dr. JB.
Hi, Sochi.
Hi.
How are
I'm
you?
in Calcutta now.
Absolutely fine now.
So when are we having next physical meeting?
I don't know.
Good afternoon, Radhika. You are all right?
Yes, sir, I'm okay, sir. I
Okay,
just got
just
checked up,
wanted-
sir.
Just wanted to find out.
So it's permitted to present directly also, right?
I'm busy.
Yes, Kansila. Whatever pre-recorded talks I had got, I've already sent it to them.
मूर्ति मैम का लाइव है मैम, लाइव बोलेंगे का है मैम. एक बार आप मेन टाइम आप एक बार शेयरिंग करके चेक कर
हाँ,
लेंगे.
मैं वही करने वाली हूँ. So I'm just sharing my screen.
Meeting live or are we going to recording conversation?
Sure. I'll come. Okay.
Yes,
Thank you.
with Sam. Okay,
Thank
sir. Okay.
you.
Manisha, what about us? जो recorded भेजा है?
मैम आपका रिकॉर्डेड चलेगा रीमा मैम.
Okay.
प्लीज मूव योर स्लाइड्स मैम. मूर्ति मैम
Thank you.
Click
अभी
on
मैं
that
नहीं
center.
देख सकती ना?
ठीक है मैम.
Good evening, sir. The first speaker, according to the list, is Dr. Pratho Pratim Majumdar. Am I right?
Yes. इसका recorded talk है आपके पास.
अच्छा, तो वो लेकिन क्वेश्चन आंसर्स के लिए भी लाइव नहीं आएंगे?
नहीं आएंगे, but we can't be too sure because सबका working चल रहा है इस वक्त.
ठीक है, तो उनका फिर ठीक से टाइम पे चालू कर दिया जाएगा फिर.
Right.
ठीक है.
Dr. Shishir Narayan may not join us.
And his recording is there with us?
It is not.
Atul? अच्छा, तो recording is also not there. So shall I consider it as a total cancel?
सर देयर
है ना रिकॉर्ड?
नहीं लाइव है सर इनका.
अशोका होटल्स है?
आई थिंक सो.
अच्छा अतुल, आपके पास लेकिन रिकॉर्डिंग तो नहीं है ना शिशिर सर की?
नहीं मैं
चलो,
इस
ठीक है.
सेशन के इसके अंदर सिर्फ 2 लाइव हैं, बाकी 4 रिकॉर्डेड हैं. फर्स्ट, थर्ड, फोर्थ, फिफ्थ रिकॉर्डेड हैं, सिक्स्थ एंड सेकंड लाइव है.
अच्छा, तो डॉक्टर अमित खोसला एंड डॉक्टर मूर्ति इज गोना बी स्पीकिंग लाइव.
नहीं डॉक्टर अमित खोसला का मैंने रिकॉर्डिंग ऑलरेडी
रिकॉर्डिंग है मैम. रिकॉर्डिंग में देखो फिफ्थ, सिक्स्थ एंड सेकंड का लाइव है सर.
अच्छा, ठीक है. 6th and 2nd का लाइव. ओके.
Questions are in the end.
Can I just clarify, Mr. Nikhil?
श्योर मैम.
सेकंड टॉक है आपकी डॉक्टर शिशिर नारायण की, उनकी ना प्री रिकॉर्डेड है ना लाइव है. ही इज नॉट गोइंग टू बी देयर. Dr. Somshila, sixth talk जो है, she's already there. She will be presenting live.
Correct.
तो आपका seventh है concluding remarks by Dr. Sudha Ganesh, वो भी live है.
Okay. Understood, ma'am. Perfect. Wonderful.
Anisha, questions after each talk है या at the end है? After each talk कर ले.
ठीक है मैम.
है ना, because then people will keep on moving here and there and you keep on calling. So I think after each talk you can ask one or two questions. That might be the best.
Yes, that's better.
Yeah,
I
very
always
quick,
feel
sir.
that is better.
Yeah.
But time control should be there.
Yes,
I
sir.
think it will be there because we already have pre-recorded talks, no?
Yeah.
Yes. Atul, if you could just check the pre-recorded talks, can you just confirm हर एक talk कितने मिनट का है, आपको वीडियो में दिखाई देगा?
इसका ज्यादा हुआ 10 मिनट में बंद कर देना.
सर जो फर्स्ट वन जो है वो 10 मिनट 55 सेकंड का है और जो
ठीक है.
थर्ड वन है वो 7 मिनट 37 सेकंड का है.
Okay.
फिर फोर्थ वन जो है 9 मिनट और 34 सेकंड का है.
Okay.
और जो फिफ्थ वन जो है वो 11 मिनट 59 सेकंड का है.
Okay.
ठीक है, we are good. Average.
I think हाँ, फिर पूरा का पूरा वीडियो ही दिखा सकते हैं, कोई दिक्कत नहीं है.
ठीक है.
ठीक है.
But
I think
today's
1-2
talk-
minutes here and there is fine. It's just that it
Yes,
really
yes.
goes on and on.
Videos actually help us, ma'am, to keep it on time.
That was the purpose. That's how we did it.
Yes, wonderful. Dr. Murthy, can I just rename you to Dr. Somashila because your name here is Dr. Kalpana Murthy.
No. Kalpana is a different person.
Yeah.
That is Kalpana Babu Murthy. Other one is so
Okay. Sorry, I'm really sorry. Apologies. I'm really sorry. हो जाता है कभी कभी, तो मैंने सोचा कि एक बार पूछ लूं. That's the reason I wanted to really confirm because यहाँ पर को कन्वेनर का नाम है डॉक्टर कल्पना बाबू मूर्ति, तो इसलिए मैंने पूछ लिया कि ये okay.
They're going to be live on 4 o'clock or 4:30.
4 o'clock.
2 minutes from now.
2 minutes. Atul from the team is going to give you a heads up, and once he says you're live, he's going to give you a countdown, and then I think Dr. Manisha Agarwal can get started, introduce the chairpersons, co-conveners, and get started with the first talk. Once he says we are having the first speaker, and आपको सिर्फ इतना ही बोलना है, you don't need to say that it's a recorded video, and we will play the video. ठीक है मैम?
Sure, Doctor. Sure, Mr. Nikhil. Thank you.
Thank you so much, ma'am. "90 seconds to go live."
We are live.
A very good evening to all of you, and on behalf of Uveitis Society of India, I welcome you all. At the outset, I would like to thank Delhi Ophthalmological Society for giving our society this wonderful opportunity. In the coming two sessions, starting from the first session now, we have tried to make uveitis a simple practice for all the ophthalmologists by creating some kind of algorithms at the end of each talk. I have the privilege and honor of inviting the chairpersons for the first session, Dr. Vishali Gupta. She is a well-known figure as a uveitis and a retina specialist from PGI Chandigarh. She is accompanied by Dr. Sudha Ganesh, who is going to be joining us soon. She is a senior uveitis and cataract specialist from Shankar Nethralaya, Chennai. Hello, ma'am. Welcome to the session. We have Dr. Kalpana Babu Murthy. She is from Prabha Eye Clinic, and she is also the Vice President of USI, who is going to be co-convening the session. We have Dr. Padma Malini. She is again a senior uveitis specialist from Narayan Nethralaya, Bangalore. And I would be the moderator for the session. So without any waste of time, since we want to salvage some time for a good discussion at the end of each talk, I would invite the first speaker of the session, Dr. Partho Pratim Majumdar, who's again a very well-renowned uveitis specialist from Shankar Nethralaya, Chennai, and he would be speaking to us on anterior uveitis. So over to you, Partho.
Hello everyone, I'll be talking on anterior uveitis. First of all, I would like to thank Uvea Society of India and Delhi Ophthalmology Society for giving me this opportunity. So I'll be sharing 4 case scenarios and will discuss the various aspects of the anterior uveitis. My first patient was a 24-year-old gentleman who presented with severe ocular pain and redness in his right eye. He also gave history of recurrent attack of uveitis and also mentioned us that his uveitis used to alternate between the right and left eye. And also he gave us history of lower backache. So when we examined him, the slit lamp examination of the right eye showed fibrinous reaction in the anterior chamber along with 0.5 mm hypopyon. And there was cells in the anterior vitreous space. However, the fundus examination of both eyes were within normal limit. So he was started on topical steroid and cycloplegic. His HLA-B27 was positive. He was sent to a rheumatologist also who examined him and found that there was a painful intersegmental restriction in the movement of the cervical and lumbar vertebra. And based on his finding, the patient was started on oral methotrexate. So our first case was a case of HLA-B27 uveitis. So HLA-B27 associated uveitis can be fibrinous, non-granulomatous anterior uveitis in majority of the cases. It is characterized by recurrent attacks of anterior uveitis that keeps alternating between the eyes. Some rare scenario, there can be severe hypotony due to the ciliary shock, and sometimes rarely the posterior segment can be involved. And many a time the patient requires systemic medication, especially if the patient is having systemic involvement or there are recurrent attacks of uveitis which are going to complicate the course of the inflammation. Our second patient was a 56-year-old gentleman who presented with ocular pain, irritation, and minimal redness in his left eye. He also gave us recurrent attacks of inflammation, but his inflammation or uveitis was confined to the only one eye, the left eye. He was getting the recurrent attack of uveitis, and he also gave us an important clue that whenever he stops the topical steroid prescribed by his ophthalmologist, he again gets the reactivation of his eye problem. So the slit lamp examination of the left eye revealed 1+ cells and 1+ flare in the anterior chamber. There are pigmented keratic precipitate diffusely distributed mainly in the central cornea. There was also a presence of corneal scar, as you can see here, and his IOP was high. So we did aqueous paracentesis and his aqueous aspirate was sent for PCR, which was found to be positive for varicella zoster virus. He was treated with topical steroid and cycloplegic and was also advised oral cyclovir and anti-glaucoma medication. So it was a case of viral anterior uveitis. So the viral anterior uveitis is usually unilateral. It typically confined to one eye compared to the HLA-B27, which keeps alternating between the eyes. And it is also characterized by presence of either corneal scar or diffuse distribution of the keratic precipitates. Sometimes we can actually see the iris atrophy, which can result from the segmental arteritis by the viruses. And also sometimes it can present with distorted pupil. So next time if you see a patient of anterior uveitis who is not on cycloplegic but the pupil is distorted, you can suspect viral uveitis in such cases. Also, the raised intraocular pressure from the trabeculitis is very common in viral anterior uveitis. PCR is a very sensitive test. However, the serology for the viruses, especially the herpetic viruses, has limited role in the management of viral anterior uveitis. Our case 3 was a 21-year-old lady who presented with complaint of diminution of vision in her right eye. She denied any history of redness or pain. When we examined, the slit lamp examination showed occasional cells, stellate keratic precipitate, which was diffusely distributed, as you can see here. And also, she had a near total cataract. And when we carefully examined her, we could find the areas of loss of fine iris pattern, and there was no synechiae. So the diagnosis was quite easy. It was a case of Fuchs uveitis. We started the patient on topical steroid, and the lady was advised phacoemulsification with foldable lens implantation. So Fuchs uveitis is often unilateral, but it is again typically confined to one eye. It is characterized by diffuse distribution of the stellate capice, and another hallmark is absence of synechiae. Though one important thing you have to remember that heterochromia, which is mentioned in various textbooks, is very rare in patients with dark irises like Indian patients. And the Fuchs uveitis does not require any laboratory investigation. Diagnosis is almost always clinical, but sometimes you may have to rule out the other causes of uveitis in challenging case scenarios. Our fourth patient was a 38-year-old lady who presented with blurring of vision in both eyes, but it was more in right when compared to the left eye. She also denied any history of redness or pain. When we examined, our slit lamp examination of the right eye showed Sales 1+, flare 1+, and Marten fat keratic precipitates. And in left eye, there was occasional cells, flare 1+, and you can see the iris nodules with the synechiae. So we started investigating the patient, and meanwhile we started the patient on topical steroid and cycloplegic. Her Monto test was negative. Serum angiotensin converting enzyme was raised. HRCT showed mediastinal lymphadenopathy. The patient was referred to chest physician who diagnosed her as a case of sarcoidosis and advised bronchoscopy, but the patient refused the bronchoscopy. So finally, the patient was started on oral steroid by the chest physician, and she was managed with the topical steroid and cycloplegic. So the learning point in granulomatous uveitis is it often runs a chronic course. So often the patient presents very late because of minimal symptoms. Usually both the eyes are involved, but one must remember that there can be minimal or absent congestion. Sometimes we can encounter the white eye uveitis. Marten fat keratic precipitates and iris nodules are very common in such scenarios, and posterior segment involved are very common. The common causes can be in India, you should rule out always the tuberculosis and sarcoidosis. However, the granulomatous uveitis can be seen in syphilis, Lyme disease, and Hansen's disease also. And sometimes some systemic disorder like Vogt-Koyanagi-Harada disease, which is a basically pan-uveitis, can present as a granulomatous uveitis. Coming to the treatment of uveitis, topical steroid, we prefer prednisolone acetate because of the acetate moiety. It has a better penetration. So though they are less potent than the dexamethasone or betamethasone, the prednisolone acetate has highest intracorneal penetration and achieves highest concentration in the anterior chamber. Cycloplegic, usually the short-acting cycloplegics are preferred, but cyclopentolate is avoided in cases with uveitis because cyclopentolate is considered as a chemoattractant and often can attract the inflammatory cells. The systemic therapy in anterior uveitis is often required when there is a recurrent inflammation and there is a possibility of complication, and also in presence of systemic disease when it is required to control or treat the systemic disease. I'll just conclude with the 4 take-home points. The number 1, we need to rule out anterior uveitis in patients with posterior or panuveitis, where anterior uveitis is a part of the inflammation. So we should not miss posterior panuveitis. So all cases of anterior uveitis, one must dilate and examine the fundus carefully. Next is laterality of involvement is very important in anterior uveitis, as we have seen in first 3 cases. So always take history relevant to the laterality or eye involvement in patients with anterior uveitis. The third point is the identification of clinical phenotype followed by tailored laboratory investigation remains the mainstay of the diagnosis and management of anterior uveitis. So always examine these patients, examine the iris, cornea carefully and look for the specific signs that may help you to clinch the diagnosis. The number 4 and last point is granulomatous uveitis requires extensive investigation to find out the systemic causes, and you need to treat them aggressively to prevent the loss of vision and further complications. Thank you.
Thank you, Partho, for that wonderful talk on anterior uveitis. And I think Partho has been unable to join us. So I'll just take up one question, and maybe any one of the speakers or the chairpersons, they can answer that. If we have a patient presenting with the first episode of a hypopyon anterior uveitis, what would be the recommended investigations in such a patient? Or do we just go ahead and treat the patient? Dr. Vishali, would you like to, ma'am, take up this question?
It will depend, Manisha, at what age the patient is presented to me. If it is a child, first episode of hypopyon uveitis, and there is no fibrin in the AC, my first instinct is to rule out leukemias or masquerades. So without wasting much time, and if there is no obvious, something, I would just do a tap and without starting steroids, because many a time the masquerades could be masked if we intensively treat with steroids. If it is an adult patient who comes with a very typical history that he remembers the time when it started, acute episode, pain, redness, alternating sometimes, I know it's Sandspont, and I will not really wait for investigation to start topical steroid, because this hypopyon would have fibrin and a very typical onset. But if on the other hand, if I'm seeing hypopyon like Dr. Rathinam described, pigmented hypopyon, I'm thinking it could be TB or I'm thinking it could be fungal, I would rather get the sample out before subjecting to steroids. So it all depends the case scenario to me.
Manisha, can I just add to Dr. Vaishali's thing? Of late, we're seeing many patients with diabetes presenting as fibrinous anterior uveitis, and that will be like a first episode. And this is very unusual compared to a HLA-B27, but the severity is there. So I think it is important to routinely do a blood sugar in many of our patients with, a severe form of anterior uveitis.
So another thing which is very common, a common mistake would be when you have a patient who has a history of a cataract surgery done in the recent past, and then comes back with an active inflammation in the eye and hypopyon. Now, very often I find, people being confused whether are we dealing with an infective endophthalmitis, or is it just an inflammatory uveitis or inflammatory reaction that you are dealing with? So are there any tips how we can differentiate between the two entities?
I think Dr. Sudha should be the best person because she does lots of cataracts. Yeah. You're muted, ma'am.
Can you hear me?
Yes, ma'am, we can.
So in case of postoperative anterior uveitis, it depends on the duration of the inflammation. If it's immediately after they've stopped the medicine, like the patient has undergone a phaco-IOL and they have withdrawn the steroids, they've completed the glass appointment, you could still think of a rebound inflammation because of the cessation of steroids. If it is earlier on in the postoperative period, you could think of infections. Or of course, a TAS, an inflammatory syndrome because of the viscoelastics, retained lens matter in the anterior chamber. These could be some of the possibilities, but I would 100% if the patient continues to have repeated attacks of inflammation, and if I do see a PC plaque or deposits on the IOL, I would also think of a low-grade endophthalmitis, and I would do an AC-TAP PCR for these patients.
Thank you, ma'am. Any other comment from anybody?
You should keep in mind
The anterior uveitis, Dr. Pathos nicely covered. I would like to add one more entity, drug-induced uveitis.
Yes.
So many times the patients might be taking drugs like topiramate or sulfonamides, or sometimes brimonidine also can cause uveitis. So the drug history will help us to find out the etiology in drug-induced uveitis.
Dr.
Cold
Biswas.
hypopyon, you might think of Behçet's disease also. Keep it in mind that they look for our systemic investigations, systemic features like that oral aphthous ulcer, genital ulcer, which patient may not be telling. It's a cold hypopyon that without mobile hypopyon, if we see, to keep the possibility of the Behçet's.
Thank you, everyone. I think we'll move on to the next talk, and I now invite Dr. Reema Bansal. She is a retina and a uvea consultant from PGI Chandigarh, and she would be speaking to us on posterior uveitis. Over to you, Reema.
Hello, everyone. Thank you, DOS, and thank you, USI, for having me here to speak on posterior uveitis. So when we see a case of posterior uveitis, we need to know whether we are dealing with an infectious uveitis or a non-infectious uveitis, because we have different set of etiologies under these two broad categories. Before that, we need to know the signs that give us some clue about the underlying etiology. For example, if we see choroiditis, by and large, we know that we are dealing with a non-infectious uveitis. And when we see retinitis, it's more pointing towards infectious uveitis. Very isolated cases are there where retinitis, for example, in Behçet's is an example of a non-infectious etiology. Now you have these two cases of different lesions, both occupying the posterior pole. The one on the left has a severe loss of vision with a solitary lesion with exudative detachment around the lesion. And the one on the right, you have a lesion which is much more superficial and not relatively good preserved vision. When you do an OCT of this, you know that the lesion on the left is a choroidal lesion because it is pushing the RPE and the neurosensory retina up. There is subretinal fluid under the lesion, and the one on the right involves only the retinal layers, indicating that we are dealing with retinitis on the right side. When you do the fluorescein angiography of these lesions, the choroiditis is typically hypofluorescent in the early frames and which becomes increasingly hypofluorescent in the late frames, whereas the retinitis lesion shows its hypofluorescence right in the early frames, which goes on becoming very intense in the late frames. So when we see a case of retinal vasculitis, it's important to do pattern recognition in the sense that what vessels are involved, whether we are seeing involvement of large, medium, small vessels or the capillaries, whether the vasculitis is occlusive or non-occlusive in nature, whether it is focal or diffuse, or what part of the fundus is involved, like the posterior pole or the periphery. Do we have any associated lesion in the posterior or in the anterior segment? And we must always look for clues of healed uveitis in the same or the fellow eye. We need to know whether the vasculitis is predominantly an arteritis, or it is phlebitis, or it is involving both the arteries and the veins. Whether there's some amount of retinitis also with vasculitis, where it could be toxo-viral Behçet's disease or SLE, or you have choroiditis along with vasculitis, which could be TB or sarcoidosis. Whether you have CME or you don't have CME with vasculitis. Look at an example of this patient with bilateral loss of vision, having perivenous hemorrhages. The vessels are completely knocked out. You have a lot of cottonwool spots in the posterior pole. And this shows the role of fluorescein angiography in vasculitis, where you can completely see the occlusive nature of this disease in both the eyes. The other clinical clues are important in telling you the underlying etiology. For example, if you have a disc edema along with the active vasculitis, or you have perivascular choroiditis scars, you are dealing with most likely a TB vasculitis. When you do a fluorescein, if you see a significant amount of capillary non-perfusion, even neovascularization of the retina elsewhere, or in the disc, you are dealing with TB vasculitis. Sometimes these patients just present with a spontaneous vitreous hemorrhage, and it's only after vitrectomy that you get to know that there have been episodes of vasculitis earlier. You may have an accompanying choroidal granuloma along with active vasculitis in TB uveitis. The choroidal granulomas of tuberculosis are typically involving the posterior pole. They're usually solitary. They have a lot of exudative response around them, and the lesions are quite vascularized, and they are occupying the space, and it pushes the RPE choroid complex forward because of the choroidal granuloma. You may have these presentations of serpiginous-like choroiditis, which are quite classical for TB, the more common being the multifocal variety on the left, but we do see placoid varieties of serpiginous choroiditis also in TB. The retinitis, when you see focal, we think of toxoplasmosis as the first differential diagnosis. You may have these kind of scars in the macula or in the periphery as the punched out scars, which give you a clue of toxoplasmosis having happened in this patient earlier. You have this significant vitritis, and you have these tongue-shaped lesions in the periphery which show acute retinal necrosis. You're dealing with viral etiology, or you may be having a clear media like this where you know that this is CMV retinitis. Fungal endophthalmitis presents with a hypopyon and yellow glow where you don't see the fundus at all, so there is dense exudation of the vitreous cavity. Sarcoidosis can present with vasculitis in any clinical finding, but when you see these kind of perivenous exudates with typical segmental cuffing and candle wax drippings with CME, we order tests for sarcoidosis. The peripheral multifocal round punched out lesions are also indicative of sarcoidosis. The granulomas of sarcoid are typically seen in the posterior pole, but they differ from TB granulomas in being much deeper, in having this reddish hue coloration, and they're multiple in numbers, and they don't have the exudative response as we see in tuberculosis. The disc involvement in sarcoidosis is not uncommon. You can have disc edema or you can have optic nerve granuloma. Behçet's disease, usually it's a panuveitis. The interior uveitis is almost always non-granulomatous and frequently bilateral. Vitritis is diffuse. There are retinal infiltrates which you may see. Predominantly the veins are affected, and you have point pattern type of vasculitis on fluorescein angiography. It's important to look for oral ulcers and lesions of the skin in these patients of Behçet's. The hypopyon is typically cold in nature, and you don't have much congestion in the eyes, and you can demonstrate shifting nature of the hypopyon in these patients of Behçet's uveitis. When you see a patient of bilateral exudative detachment, it's important, mandatory to do a fluorescein before we start the treatment in order to rule out mimickers, and of course to do an OCT to check for choroidal thickness and the subretinal fluid. You may have a patient presenting in the convalescent stage like this with festoon pupil and sunset glow fundus, nummular scars in the periphery. So we must not ignore looking at the patient systemically, look at the eyebrows, eyelashes, skin around the eyes and the hand and elsewhere. So posterior uveitis needs to be narrowed down to infectious and non-infectious etiologies for differential diagnosis. So if you think of infectious, you may think of TB, viral, toxoplasmosis, fungal, Lyme's disease, and Bartonella. Non-infectious etiologies are common in terms of PKH, sarcoidosis, Behçet's, sympathetic ophthalmia, and various white dot syndromes. Thank you very much.
Thank you, Reema. And that was a wonderful talk covering the entire aspect of posterior uveitis. One very common mistake which we find in our clinics where the treating clinician has gone wrong in diagnosing is a fibrinous CSCR with choroiditis. And we all realize that the treatment line is totally different. One requires steroids, and in one entity, the giving of oral steroids can be very much damaging to the patient. So are there any tips from your side to differentiate between the two entities?
Yeah, Manisha. Choroiditis, because once you see these patients as during the initial presentation, the clinician is likely to make a mistake. First thing we need to do is look for some cells in the vitreous or in the anterior segment. So the moment we have any clue of inflammation, so we know that we're not dealing with CSC. So that rules out CSC. But if we don't have cells, that does not really rule out choroiditis, because choroiditis at times may not, most of the times may not have cells in the anterior segment as well as in the vitreous. So the next sure shot sign is, of course, clinical clues. If we have disc edema, that's also one clinical clue where you're dealing with an inflammatory etiology. So disc edema with CSC is unlikely. And the next confirmatory test is to do a fluorescein angiography. So whenever we see these patients of choroidal lesions, like I mentioned in my talk also, exudative detachment or any kind of choroiditis, we must do a fluorescein before we start the treatment, because many times these mimickers are simply ruled out by fluorescein angiography.
Any other comment?
OCT, whenever we have an RPE bump or PED, is commonly associated with CSCR than in uveitis. In uveitis, whenever we have a subretinal fluid, we can have associated vitreous cells in the form of posterior vitreous cells. That again can give us a clue to differentiate between CSC and posterior uveitis.
I think another important clue when we are clinically trying to differentiate between the two is that in fibrinous CSCR, we find these very typical areas of clearing in between the yellowish
track of the serous fluid
that we see. And often you can see RP tracts also in these patients, which again would suggest that these patients are of chronic CSCR. And of course, all the other signs of inflammation that we can look for in these patients. But I think one has to really make sure when we are, trying to differentiate between these two entities. So thank you so much, Rima, and we'll move on to the next talk now.
Thank you, Manisha.
I would now invite Dr. Biswas, who is the head of uveitis and ocular pathology, Shankar Nethralaya, Chennai. And sir would be speaking to us on retinal vasculitis. Over to you, sir.
I'd like to thank first Delhi Ophthalmological Society for giving me this opportunity to talk on retinal vasculitis. Retinal vasculitis is the inflammation of the retinal vessels in the inner plexiform layer of the retina. Periphlebotitis is much more common than periarteritis, and Eales disease is the most common retinal vasculitis seen in India. Retinal vasculitis can be various causes, which include primary Eales disease, which is now thought to be immunologic reaction to Mycobacterium tuberculosis DNA. It can be associated with uveitis. It can be associated with the collagen diseases, can be associated with the infection, associated with the neurologic disease like multiple sclerosis. The approach for retinal vasculitis to ask the question, is it retinal vasculitis alone? Is it ocular alone? Is it associated with a systemic disease like autoimmune or infective? Here is a montage fundus photograph showing an Eales disease case showing active perivasculitis in the mid-periphery of the retina. It's now thought to be an immunologic reaction to the Mycobacterium tuberculosis DNA seen in the healthy adults, 15 to 40 years, predominantly male. It was used to be seen in 1 in 135 ophthalmic patients at Shankar Nethralaya. Now it has reduced a lot. It has got a characteristic natural course, which starts with the inflammation initially, followed by the ischemia and capillary non-perfusion, leading to the neovascularization and subsequently fibrovascular proliferation with vitreous hemorrhage and tractional retinal detachment. We did high-resolution computerized tomographic chest, and which showed latent tuberculosis in around 50% cases. Here is a photograph showing T-in-bud appearance of an HSCT of a chest of a case of Eales disease. We also looked for further evidences of association of latent Mycobacterium tuberculosis in Eales disease. We found MANTO positivity in 73% cases, quantiferon TB gold test 56% cases, high-resolution CT chest 34% cases,
cases, aqueous PCR 33% cases, and vitreous PCR when the vitrectomy was done in 22% cases. Imaging of the Eales disease, fundus fluorescent angiogram showed typically vasculitis, capillary non-perfusion, and venovenous shunt. We found ultra-wide field imaging in Eales disease is helpful in documenting the hemorrhages and retinal perivascular sheathing neovascularizations. You can see a orthos fundus photograph showing perivasculitis in the far periphery, as well as the wide field fundus fluorescent angiogram. What I'm doing now is the Swepsos optical coherence tomographic angiography in various retinal vasculitis. Here is an Eales disease case. We can see the neovascular front at the periphery. We can see the foveal vascular architecture alteration with the Swepsos optical coherence tomography. We can also see the vascular beading in case of idiopathic retinal vasculitis with aneurysm and neuroretinitis. We did the long-term outcome of a large cohort of patients with Eales disease, 500 patients, 898 eyes, with a follow-up of 10 to 25 years. And we have shown that the bilaterality is seen in 81% cases, and acute stage oral steroid has got better prognosis, laser treatment in the proliferative stage, and there is better prognosis. Recurrence is seen in 52% cases in 10 years period, more than 5 recurrences. The common retinal vasculitis which closely mimic Eales disease are sarcoidosis, Behçet's disease, and systemic lupus erythematosus. Retinal vasculitis can be associated with uveitis like Behçet's disease, sarcoidosis, syphilis, CMV retinitis, intermediate uveitis, and acute retinal necrosis. Behçet's disease presents with the characteristic painful aphthous ulceration or genital ulceration, and sometimes erythema nodosum can also be seen, and it has got a vasculitis with exudates, with vitreous haze, and sometimes optic nerve involvement. The fundus fluorescent angiogram is often characteristic, showing capillary furning as seen in this picture. Retinal vasculitis and sarcoidosis can often be presented with candle wax dripping and can have systemic examinations with the bilateral hilar lymphadenopathy on chest X-ray or HRCT chest, and even if the extra ocular manifestations like cervical lymphadenopathy, biopsy is done, non-caseating granulomatous inflammation is seen. Infection associated with the retinal vasculitis are tuberculosis, cytomegalovirus retinitis, toxoplasmosis, syphilis, and acute retinal necrosis. Here is a case of CMV retinitis with active retinal vasculitis. One can have chyleriasis arterialis with active toxoplasmic retinochoroiditis. Serpiginous choroiditis can rarely be associated with retinal vasculitis. In such cases, tubercular etiology should be suspected. Retinal vasculitis is an important component of the triad of acute retinal necrosis. We can see also retinal vasculitis occasionally in syphilis cases. Here you can see the vitreous exudates and some retinal vasculitis underneath it. Collagen disease top on the list can be associated on the retinal vasculitis, is systemic lupus erythematosus, but rarely granulomatosis with polyangiitis and polyarthritis nodosa. We have found active vasculitis in 27% cases in a series of systemic lupus erythematosus retinal vasculitis and Hill vasculitis in 23% cases. This is a case of a systemic lupus erythematosus induced retinal vasculitis and associated retinal vasculitis. You can see the bilateral malar rush and retinal vasculitis with cotton wall exudates. Positive anti-DS DNA is a hallmark in a case of SLE. Prostate branch angiitis is a variant of retinal vasculitis. One can see in case of rubella, which we have reported. One can see in case of tuberculosis, we have reported a case of a 17-year-old girl, biopsy-proven abdominal tuberculosis with prostate branch angiitis, which resolved with treatment with ATT and steroid. While prostate branch angiitis can also occur in CMV retinitis as seen in this picture. We have seen in non-infective conditions like sympathetic ophthalmia can also show signs of frosted bronchitis. We feel frosted bronchitis is a sign only and can occur in various diseases. Retinal vasculitis is neurologic disease, is multiple sclerosis, and we have reported a case of recurrent anterior uveitis with healed retinal vasculitis with multiple sclerosis. Here you can see the posterior limb of the internal capsule and corona radiata in white lesion and with the active retinal vasculitis. What are the investigations which you do in case of retinal vasculitis? It should be tailored and focused and stepwise approach. And investigation is often not contributory. We have found Mantoux positivity in 30% of the cases, but TB was seen in 5.71% cases. Raised serum ACE level and positive antinuclear antibody was seen in 5.7% cases. Management of the retinal vasculitis is not difficult. In case of infection, treat the infection first. Primary or associated autoimmune disease, systemic steroid first. If not responding, one can switch to immunosuppressive agents. But in case of EASE disease, inflammatory stage, treat with the corticosteroids and ATT, neovascularization, laser photocoagulation, vitreous hemorrhage, tractional retinal treatment, vitrectomy with endolaser. So this is a case of an EASE disease with active retinal vasculitis and which was Mantoux positive, quantiferon TB gold test positive, high resolution CT chest positive, and you can see the marked resolution of inflammation after a course of ATT and steroid. In case of Behçet's disease, immunosuppressive agents are the first choice, and cyclosporin is the most commonly used drug, and you can see the significant resolution of inflammation after a course of cyclosporin tablets. Biologics in retinal vasculitis is a new weapon in the armamentarium of retinal vasculitis management, and we have reported several cases of uveitis and scleritis responding to biologics. And this includes a case of Behçet's disease, which is resolved with a subcutaneous injection of adalimumab with biologic agents. In conclusion, retinal vasculitis can be associated with various ocular and systemic diseases. As mentioned, ultra-wide field imaging is particularly useful to document peripheral vascular changes in EASE disease. Frosted bronchitis is a sign only, not a separate disease. Management depends on the etiology of retinal vasculitis. Systemic steroid works in majority of the cases. Immunosuppressive or biologicals are beneficial in Behçet's disease. Thank you very much.
Thank you, sir, for that wonderful talk. Again, it is a very vast topic to be covered in 10 minutes, but I think you've covered it very well. I have a few questions, sir, for you. One is that in the current times, how often would you really diagnose an idiopathic vasculitis, that is termed as Eales disease, in your clinic, or do you often find just a secondary vasculitis which would have some underlying etiology?
So right now the Eales disease is like obsolete terminology. Either it's a tubercular retinal vasculitis or it's an idiopathic retinal vasculitis after ruling out the tubercular etiology. And most of the case, the clinical phenotype is of tubercular retinal vasculitis. We see a very small segment of cases of idiopathic retinal vasculitis that are ruling out SLE, Behçet's, and sarcoidosis. So in our country, actual idiopathic retinal vasculitis, we don't see that often.
And tubercular vasculitis, very often what we face is that when we send it to our physician, they say that they're not able to find any evidence of active COX systemically in the patient. So do you recommend or do you have any clinching signs where you are very sure clinically that you are dealing with the tubercular vasculitis, or you opt for an interventional diagnosis like a PCR before you are going to recommend starting ATT in your patients?
No, I don't do PCR for the cases. Based on the ancillary investigations like laboratory investigations like HSCT chest, Mantoux, quantiferon TB gold test, if these are positive, any one of them, I put them ask them to reason ocular TB. It's not systemic TB. There's no surprise that you don't find any systemic involvement. I strongly recommend them to start anti-TB treatment as the patient is put on steroid to prevent the recurrences.
Any other comments? Dr. Sudha?
Mute me. I think some of the patients with TB vasculitis, they have a patch, if you closely look at healed choroiditis patches with pigmentation very close to the area of vasculitis. That may be a clincher in some of the cases, and most of them are occlusive vasculitis.
So that could be a clinical sign which would make you suspect underlying tubercular etiology.
Yes.
Vishali ma'am, anything to add?
No, I think just besides the routine vasculitis, sometimes people have to be aware of IRWAN, which is basically arthritis. And if you see those knots on either side of it and capillary non-perfusion, I think it's important, though you might rule out tuberculosis, but still if there are no signs of TB or sarcoid, it's IRWAN, so it needs a different line of management. And very rarely SUSAC, though we don't see that very commonly here. But if you see fusiform vascular leak, which is in isolation in a young adult, think of SUSAC. Rest, everything is beautifully covered.
One more question, JP sir. As far as the Behçet's disease is concerned, I think these are the patients who often require to be on immunosuppressants. But you know, we find very undertreated Behçet's disease patients in our clinics. What would be your recommendation when you are dealing with a patient of Behçet's?
I combine cyclosporine with azathioprine, all the cases.
For how long?
And if the patient can afford, I put on them on adalimumab.
And for how long would you continue your patient on these?
So we continued for quite a long time only. The ocular lesions is suppressed. Then we consulted the systemic people, internists and rheumatologists in particular, to look for how long they need to continue for systemic Behçet's disease. But at least for 6 months to a year, I could give the treatment till I see the resolutions completely.
Any role of intravitreal injections in these patients, such as Ozurdex?
No, I don't give. It's
Vishali
so well controlled with the injection adalimumab. They don't need to require for injection Ozurdex or intravitreal triamcinolone injection.
Not for vasculitis, because by and large vasculitis is bilateral and has associated systemic. So they do require immunosuppression for the background check activity. However, if there is asymmetry and one eye is showing more cystoid macular edema and more, then instead of adding a second immunosuppression or move to biologics, I try to keep the background inflammation under check with immunosuppression and top up the worst eye with local Ozurdex.
So thank you everyone, and I'll move on to the next talk, and I'll invite Dr. Amit Khosla to speak to us on pediatric uveitis.
Good evening. My topic of the day is approach to pediatric uveitis. I'd like to thank my pediatric rheumatology department for studying with me for the last 21 years. The journey is different for a child with uveitis, since the child cannot share one symptoms, is generally asymptomatic, and examination is different. I reviewed my cases of last 1 year, where I found I was following up 148 cases. Majority were JIA uveitis or HLA-B27 uveitis. And my 90% of mine were anterior uveitis. I compared my data with a publication from the same city from AIIMS, where they found that 40% had anterior uveitis, 25% had intermediate, and 18% had pan uveitis. So a larger segment of patients generally have a pan or a posterior uveitis in children, and 15% had infectious. So 85% are non-infectious. I tried to do a survey of various articles. A study from US said about 95% were non-infectious. So we compare the North India data with South India data, which says that about 15% are infectious, and though about 50% would be interior, but a large segment have a posterior uveitis. Another study from North India, from Chandigarh, also confirms this. So in children, we tend to have chronic interior uveitis and posterior uveitis. The problem in children is that it has associated with a significant ocular morbidity and severe vision loss. So it's important to localize the disease in the beginning and understand the significance of the morbidity. If it's limited to the interior segment, the commonest cause would be juvenile idiopathic arthritis and chronic idiopathic anterior. In posterior, TB is a common segment in association with toxoplasma, which is the commonest infection in the posterior segment. So if you were to think of etiologies, GIA dominates about 50 to 80% interior. About 15% vasculitis, majority are idiopathic or tuberculosis. And in posterior, again, tuberculosis or toxoplasmosis. In a recent article in survey, they have shared the data of complications, which say there's a high association of band-shaped keratopathy, posterior synechiae, peripheral synechiae, cataract, and glaucoma. We need to act aggressively to prevent these complications. Commonest subset of interior uveitis being GI uveitis, which is divided into various groups, and the commonest one which has uveitis is oligoarthritis. In association, you can have a separate classification or a part of GI is called enthesitis-related arthritis, which is HLA-B27. So in uveitis, you may have HLA-B27 uveitis, which may be like an acute interior uveitis, or the one with ANA positivity and oligoarticular have a chronic anterior. And majority of them would be chronic and have maybe multiple attacks. And they are generally asymptomatic. It's important to understand that this uveitis occurs at a younger age of onset and may be independent of the joints. And since it is asymptomatic, several publications inform us of the role of screening and monitoring these patients to prevent visual morbidity. Those patients who had early treatment had better visual outcomes, and especially those where the steroid-free remission was the goal. And the management of GIA requires an ophthalmologist who is well versed with GIA and a rheumatology team to have better outcomes. As mentioned before, it is important that this subset of patients be regularly screened, especially the ANA positive every 3 months, and the ANA negative can be every 4 to 6 months. The aim of treatment in GIA is to control the uveitis and make the child steroid-free both as drops and oral steroids. The remission period should be minimum of 2 years before you start tapering the immunomodulatory. The aggressive and early treatment helps us maintain the vision. The aim is to prevent cataract and glaucoma in CM. Normally in uveitis, we follow the step-ladder pattern of using topical steroids followed by systemic and immunomodulatory therapy. But now we are aggressively using immunomodulatory therapy as the first line of treatment. And in those which don't respond, we use biologicals as the second line of treatment. The various articles published over the last 20 years show that about 70% of these children respond to methotrexate, which is commonly used for these patients. But a subset of patients respond better to adalimumab, and this Sycamore trial showed us the utility of using biologicals in GI. The various guidelines have been formed to treat this uveitis. Some are aggressive enough to say that we should have zero tolerance to inflammation, while some guidelines say, yes, we can accept 0.5 cells. So I am more happy with targeting zero inflammation, and which has shown in my last 21 years of experience that we have lesser complications. The various outcomes published to today, the largest series published in non-infectious uveitis of biological, shows that 1/3 of children received biological therapy. So today, you want to understand that we have to be very aggressive with use of IMTs and biology. My pediatric rheumatology team reviewed our own data and we found that it takes up to 3 months for the 90% of these patients to get controlled, while 100% would have less than 0.5 cells by 6 months of treatment. But we need to understand that all arthritis and uveitis may not be GI. This child was diagnosed with GI at 9 months of age, was on methotrexate, switched to alternative therapy, came back with multiple joint deformities, and was put on tocilizumab. The patient developed initially anterior uveitis, followed by panuveitis and vasculitis, which resolved with immunomodulatory therapy. But the child on biopsy turned out to be sarcoidosis. So in children, especially who have immunological disease, the markers may change with time and manifestations will change. You should not think that all arthritis with uveitis is GI. With the third subset, one where you may have ANA positivity but no manifestation of JIA, where the uveitis presents before the arthritis or it may be independent of the arthritis. And these respond to steroid but have higher complication rate, and we tend to give immunomodulatory therapy, especially methotrexate is very popular in this treatment on a regular use. This child who had a cataract had 0 cells but had a CME and a disc edema, which took about 2 years to resolve. The second subset of uveitis is intermediate uveitis, which may be idiopathic like pasteuritis, or in India we may see tuberculosis, and rarely we see toxocara and toxoplasma initially presenting with vitritis. We use the stepladder fashion, but we prefer the immunosuppressive because we found that our results are much better with early use of immunosuppressive and biologics. I tried to compare the adult and childhood intermediate uveitis, and we found that the delayed presentation and risk of amblyopia is higher in pediatrics. I reviewed my 14 cases and found that some were presented with acute presentation of epiretinal membrane. 5 out of 14 required biologicals, 1 required vitrectomy. Here's a patient who, despite treatment, had an aggressive pars planitis. So even if the child is 6 years but has an aggressive snow banking, we should treat this patient to prevent chronic thysis bulbi and hypotonia. Second child who presented with vitreous haze and a membrane at the time presentation, the vitreous haze disappeared, the membrane remained persistent. Third subset may be small vessel vasculitis. An SLE patient presented with myositis, fever, and blurring of vision, had a picture like pustular retinopathy, but responded to methylprednisolone and cyclophosphamide induction. Ocular tuberculosis can present both as anterior and intermediate, and especially sometimes as panuveitis. This child was treated for 1 year as chronic anterior uveitis, had glaucoma due to steroids, is now responding to systemic ATT after doing a CT chest and doing a biopsy of the lymph. One of the commonest causes of panuveitis is Behçet's. In India, it is rare, but we have these children who presented with mucosal lesions, arthritis, and a relapsing and remitting course. These patients respond well to IMT and especially biologicals. Here, this patient was not responding to for 4 or 5 years with IMT. On adding adalimumab, had a response of remission of the disease. And the child is still on few years of biologicals. Sometimes the panuveitis may have no markers positive. This child had a vasculitis with a panuveitis, but HLA-B251 negative, who responded to IV methylprednisolone, methotrexate, and biological. Here you see over a period of 9 months, the child responding and having 6/9 vision. So it's important that you be aggressive in your management. 15% of pediatric uveitis are infected, which may be congenital, commonest being toxoplasma and the other TORCH group, which require the anti-infective treatment. You may also have a late onset of these infections, which may be acquired and which require appropriate treatment. So it's important to understand that you need to differentiate at the beginning whether the uveitis is infective or non-infective. In summary, I like to highlight that especially the non-infective uveitis, zero tolerance to inflammation, early use of immunosuppressive and biologicals. It may have a systemic disease for which you require a pediatric rheumatologist. These children have asymptomatic disease and late diagnosis, a high rate of complication. So regular screening prevents ocular morbidity. And last note, a multidisciplinary approach is important. So it's important to have a teamwork and create a team around you which helps treat these children better. Thank you.
Thank you, Dr. Amit. And again, I think pediatric uveitis is a specific field in its own, having some overlap with adult uveitis, of course, but also has certain specifics that we need to keep in mind. So I just wanted to ask Dr. Amit, what are the most common mistakes that you see when a child with pediatric uveitis is referred to you? What are the most commonly done mistakes by any treating, ophthalmologist who is not so much geared up in dealing with pediatric uveitis?
The first thing is, can you hear me?
Yes, Dr. Amit.
Yeah. So the first thing is the early diagnosis. So all the pediatric rheumatologists must tie up with an ophthalmologist for the screening. And when you start examining children, it takes time to get the confidence. So the way you examine on a slit lamp is the most important, because sometimes the child is so uncooperative and you have to make friends, call them multiple times, and then look up for the cells. And a good slit lamp is important because the slit lamp on the microscopes in the OT do not pick up mild cells or this thing. A slit examination of anesthesia, we tend to miss out. So it's important that you create a small seat on the bench on the slit lamp, and the child can even have examined a 9-month child on a slit lamp. So you have to learn the art of first examining these children. Number 2 is that you need to start early. And in India, you really find that one subset which people say that you can go get away with topical steroid is those one with no synechiae, no cataract, no BSK. You really find these patients, who have disease but no comorbidity in the eye. So you require IMT in all these patients. You must from day one plan a methotrexate. And I aim for a zero tolerance. By 3 months, I should be off topical and oral steroid. If the patient can't afford a biological, then we allow up to 2 drops a day, which is supposed to have least chances of glaucoma or cataract, and then shift to biologicals, or you add MMF if in 3 months you don't get a full control of the uveitis.
Yes,
I would just like to add, I think children cannot be taken lightly, like Amit said. It's always best to be very aggressive right in the beginning and don't get carried away by getting away with the, just topical drops or trying anything exotic. Like I would vouch for myself, maybe 10 years ago, our group, we thought we were such great surgeons that somehow pediatric cataract surgeon tried using IOLs in JIA patient, and we even reported, publications and everything, Ozurdex and no inflammation, getting control. Now, 12, 13 years later, I'm looking at them and, many of them need to be explanted, ACO, PCO, things going wrong in the fundus, no view. So I would be very, very conservative and very aggressive with children. I totally agree with Amit. There has to be very low threshold for stepping up the therapy in kids.
If you go into hypotony, then it's a real problem in these cases.
I agree.
I think when we see the BSK in children, that's a sign of improper control, and we should be very aggressive.
And maybe it's because of the place we are seeing. We generally see children with BSK. We don't even see the garden variety, in children.
So, Manisha, can I add one point?
Yeah, sure.
So wonderful talk, Amit, and you've really covered up all the points. Just to emphasize what you said, that the patients come into us so delayed in their presentation, in their clinical course, that so when we looked at our data, we saw that almost 50%, 49% patients had low vision of less than 3/16, at least one eye. And about 74% patients entered in with complications. It was either cataract or glaucoma or subretinal fibrosis or one or the other complication. So literally they enter see a pediatric patient with uveitis, the approach has to be very, very different and very aggressive. And corticosteroids, oral steroids, which are the mainstay in primary care or secondary care, cannot be the mainstay of therapy for these patients.
And even, hypotony, silicone oil for hypotony, I think it's too overrated. The short-term results are good. Like, they are the ones who reported it, to be very honest. But today, when I get a child referred to me for silicone oil, I don't want to inject, because I know that after 10 years, once you have reached a stage where you got to inject, it doesn't work. So I would rather treat them like you all say, right in the beginning.
I think there's one more thing which probably, I would like to add what Amit had said. Earlier, we used to just put it as broadly granulomatous uveitis, and now we're picking up more of Blau. So these patients, actually, if they're treated very well initially, they're they do very well over a period. We ourselves published a series recently, and they're doing extremely well with 6/9 vision with aphakic correction and a good immune suppression. They generally do very well. So I think now that I think PGI is doing it, the testing, and many of us have benefited with that, technology which is available now. So it's worthwhile looking at patients with granulomatous uveitis, because when they present initially, they present only with anterior uveitis. And if you kind of leave it like that, then they go in for posterior manifestations and all that. So I think that is something which we also need to keep in mind, because it helps us to start off medications at a much earlier stage.
Yeah, many patients we thought of as sarcoid.
Yeah, right.
Many years. I'm sounding too old. Everything is 10 years old. So they are now not too positive, and we are revising the diagnosis to Blau. I agree.
I think one message which I really want to highlight again, though Dr. Vaishali mentioned that in JIA patients, I think it is best that they are left aphakic. So initially, it may be very gratifying that you've been able to put the IOL in these young children. But at the end of the day, I think you have actually done more damage to the child rather than benefiting. Because most of the time, we land up explanting them with a lot of inflammatory response, membranes over the ciliary body, ciliary processes, and hypotony. And, we have really lost the eye at the end of the day. So I think it is best not to feel so much happy, by putting the IOL for some time. It's best that these children are left aphakic. The other thing which I wanted to ask all of you to give a comment on is that what would be your threshold of shifting these children with uveitis to immunosuppression? Because we often get children who are having all features of long-term systemic steroid therapy.
Yeah.
And somewhere down the line, people don't feel confident in starting immunosuppression in children. So what would be your take? Let's start with Dr. Sudha and have a quick comment from all of you.
I think, Manisha, initially we start with steroids, but we don't wait for that long. We need to be aggressive, and we do put the patients on methotrexate. And if they fail methotrexate, we can go on to Azuran or the biologics. But we need to give some time for the immunosuppressives to act before we shift to biologics. But going on to immunosuppressives from steroid, most of the children tolerate it very well, especially methotrexate. At least in my opinion and in my experience, I've had a lot of children on methotrexate. And when they don't respond, and the response is not judged in just a month or 2 months' time, I give them quite a bit of time, like at least 6 months of therapy. Patient has repeated recurrences, then you are justified in either adding an immunomodulator drug, or you could switch to biologics. where adalimumab would be the best. In our hands, that is what we have tried.
Padma?
Yes, in children, initially we can start with steroids, but we don't give it for longer duration. We introduce the immunosuppressants at the earliest. Like Stan said, the methotrexate works well in most of the pediatric uveitic cases, but if the patient has aggressive disease like Behçet's and things like that, then we go for biologics in addition to the methotrexate. Adalimumab works well once in 2 weeks regimen. Suppose if the child is not responding, some of the cases we step up the dose. If in spite of that, if it's not, then we started giving once a week regimen. In that, most of the kids, they respond.
I think we are all, Kalpana, would you like to add anything?
Actually, I agree with Amit because I have a very good pediatric rheumatologist and a good team. So my threshold for starting immune suppression in children is very low. So we started very early, and we prefer methotrexate and mycophenolate. These are our preferred combinations in children. And if we know the disease, like the etiology, especially JIA, or if it is a sarcoid, or if it is Behçet's, then our biologic targeting becomes much easier. For me, the problem is the ones which have intermediate uveitis. They are the ones which are very difficult for me to manage. So if they are treated very early, I get away with methotrexate and mycophenolate combo. But generally, these patients, again, even with adalimumab, they don't settle down. Even with tocilizumab, they don't settle down. So these are a very problematic group for me, intermediate uveitis with refractory CMEs. But by and large, they generally do very well now compared to what my group was 10 years ago. The children who are there right now, they do extremely well with very, very low complications.
I think any child you need to give systemic steroids would need immunosuppressants.
Immunomodulators.
By and large, in my principle and practice.
So
If you were thinking of giving steroids, then you must start methotrexate simultaneously and use steroids only as build therapy for 3 weeks, and you go to methotrexate solely.
That's how our pediatric rheumatologists do all the time.
And I think the tolerance with methotrexate in children is extremely good, and they can be on methotrexate for several months to years without any side effects.
Because with azathioprine, we used to get a lot of leukopenias. So I think now they have generally shifted to mycophenolate for children.
Methotrexate and biologics.
Correct,
They're very comfortable with biologics.
Correct, with methotrexate, true.
And also the post-COVID, we are getting more of leukopenia with azathioprine. You have to be extra careful in post-COVID cases.
Subcutaneous
Move on to the next one. Yeah, Dr. Sudha, please, sorry.
I just wanted to add subcutaneous methotrexate works very well in this.
Absolutely. I think the bioavailability is also much more with the subcutaneous rather than an oral dose. I'll now invite Dr. Somshila Murthy, and she would be speaking to us on scleritis. Over to you, Somshila.
Thank you very much. First of all, I would like to thank Dr. Manisha and DOS for inviting me for this presentation. Is my slides getting shared? Not yet?
They're shared. You can just do a slideshow.
Okay. So I'm going to turn off my video because I think my connection, it says that my connection is unstable or something. All right. So Manisha had given me the task of talking about the algorithms in the management of scleritis through case examples. And I thought that through 4 different or diverse kind of cases in scleritis, we could just simply go through the management strategies. So everyone is familiar with this class. Of course, certainly this group is extremely familiar with this classification, which was proposed by Watson and Hayre, probably the most useful one. And to that, we have additional inputs from other authors. And in addition to that, I thought that it's also interesting that if we could add masquerade as well. And though we know there's anterior and posterior scleritis, sometimes I wonder if we should call certain cases the span scleritis when it's very severe. When you talk about non-necrotizing and then necrotizing, when you say with inflammation and without inflammation, I think that, as Professor Narsinga always says, that there's always inflammation in all sorts of scleritis. And to wrap it up, we have surgically induced necrotizing as well as diffuse scleritis. So to me, this completes the entire classification, and of scleritis. And this is what we can use as a starting point for the algorithm. So the first case I have is a lady who first presented to us almost 17 years ago. She was 37 years old and she had redness watering pain for a year, and she had undergone cataract surgeries 2 years prior coming to us. Over a period of time, she developed various other manifestations. She was extensively investigated by us, which included nasal septal involvement and also lower limb. She had relapsing myalgias. So all her initial workup, including ANCA as well as RA, as well as whatever you could think of as negative. So these were the clinical photographs on the very first time of her presentation, which shows a bilateral diffuse scleritis with peripheral corneal infiltrates. So all these were the investigations that she had undergone a couple of times actually over the years, and initially started on oral steroids with methotrexate added. The disease was still active, so cyclophosphamide was added, as well as the intermittent severe episodes were managed with intravenous methylprednisolone pulses. So this was the course over the next several years. This was in June 2003. In September, again, she had severe reactivation. In October, again, the disease was active. And during the time, 2 years from the initial presentation, she had the classic saddle nose deformity, which happened after nasal septal inflammation. So finally, we could get this patient's disease under control with the use of tocilizumab. So this is the clinical pictures in December before the lockdown, and since then she's been in contact with us. So this is a patient who had nothing but relapsing polychondritis and has a 17-year-old history of recurrent scleritis, recurrent systemic disease, of which is what happens with relapsing polychondritis, and multiple various chemotherapeutic agents that were used for her over a period of time, finally settling down with tocilizumab. The second case is another patient with immune-mediated scleritis. This 68-year-old lady presented with complaints of severe disease, although she had the disease for quite some time, for the past 10 days, and her vision also had dropped suddenly. She was a known case of granulomatosis with polyangiitis, and also she was RA factor positive, so she was also diagnosed as rheumatoid arthritis. She unfortunately had developed pulmonary COX, for which many of the drugs that she was on had to be withdrawn, and she was hypertensive. She was using oral steroids and anti-acute tubercular therapy, and recently had just been initiated on cyclophosphamide pulses, but she was diagnosed as pulmonary COX, and therefore that had to be withdrawn. The patient was referred to us because of her active scleritis and also the peripheral corneal involvement regarding the necessity of a patch graft. So at the time of presentation, her CA was strongly positive, RA factor was raised, and the anti-PR3 antibodies are also strongly positive for this patient. So the course of the disease was that, well, we did not do a scleral patch graft for her. We decided to observe her, and as soon as sufficient anti-tubercular therapy was given to the patient, as well as the oral steroids to control the acute disease, the patient was once again resumed on immunomodulators, and there was a resolution of the scleritis. The patient was continued systemically on immunomodulators till she passed away just before lockdown due to chronic lung infection. So basically that was a case of GPA with necrotizing scleritis. The third case is totally different now. This is a 44-year-old male patient. He gave a 2-month history of pain and redness. And at the onset, he also gave classic history of noticing lesions on the forehead. So when the patient presented to us, he was on oral steroids for his scleritis, but every time he would step down the oral steroids, the condition would flare up. And what he had on examination, at this point, he was probably on 30 or 40 milligrams of Vizalone, was a pretty aggressive looking sort of a slightly nodular scleritis, more located to one area. But what was more prominent were these corneal nodular opacities in the periphery. So based on the history of lesions on the forehead that were noted at entry point, it is very easy to think of this patient as having herpes zoster ophthalmicus, and this is the scleritis with the nummular keratitis related to HZO. So this was the OCT of that area, showing that both the superficial as well as the deeper areas were involved. This is the scleral tissue showing involvement and thickening. So this was a patient with scleritis. When we stepped down his oral steroids, there was initial worsening, and there's more area of congestion, as you can see here, and also on the OCT, where suddenly you see that there is increased amount of scleral edema. But the patient finally resolved. We started antivirals for this patient, and he achieved a sort of a very good resolution following that. So that was a case of viral scleritis. Coming to another case, this was a 45-year-old with sudden onset of pain, redness, etc. after soil falling into the eye. When he presented to us, his eye was diffusely congested. There was no focal area that we could go in and sample or scrape. So we started this patient on broad spectrum antibiotics, did not have much response. Subsequently, the patient gradually began to show this focal areas of conjunctival ulceration and the scleral ischemia-like appearance. Initially, we were thrown off track. We started this patient on oral steroids, but subsequently, we got Pseudomonas from scleral biopsy, and we were finally on the right track. And after about 20 weeks from the initial presentation, the patient subsequently resolved with the help of topical amikacin eye drops. Another patient who also gave history of trauma while chopping wood. Once again, at entry, there's a very diffuse, angry-looking eye. In fact, some of these patients also present with orbital inflammation sometimes. But as the course of the disease goes by, subsequently you may see these discharging sinus-like lesions. And from one of these lesions, we could isolate fungal infection for this patient. And once we instituted antifungal medication, the patient improved dramatically and only developed a cataract later down the line. So this is another case of infectious keratitis due to fungal etiology. Another patient, so a different case was of a patient who had a single temporal ulcerated lesion. This was a middle-aged gentleman and who also gave some vague history of trauma. As the patient, as you look closely at the lesion, you notice that the surface looks a little unusual and very white and sort of keratinized. And when the patient looked down, you could see this multilobulated area over here. Initially, it was thought to be infectious scleritis. The patient also underwent scleral biopsy from that area. Multiple investigations were done to look for serological possible entities that the patient might have, but all the workup was negative. Patient was started on antibiotics, but then rapidly worsened. This was a lesion after biopsy. And eventually we came to the right track that this patient had OSSN. We missed that at the very first visit that the patient came in. So the patient ultimately had to undergo exenteration because there was a diffuse OSSN with orbital involvement. So this was a masquerade which looked like ulcerative or a nodular kind of a scleritis, but this actually was a nodular ulcerative variant of OSSN. So these were the 4 or 5 very different cases that I had to present to you. And we'll go back to Manisha. Thanks
so
very much.
Thank you so much. And all the 4 to 5 cases that you showed were telling a history of their own and were having great learning points. My just one simple question, Somshila, to you is that when would you really consider doing a biopsy, especially when we have a patient coming back to us with nodular scleritis? So, I myself am dealing with a patient who's a lady, middle-aged lady, and whenever I tell her that I have to do a biopsy, because whenever she is on steroids, she does well. And the moment you stop the steroid, she comes back with a recurrence. I really don't know that, how you are able to convince them for doing an interventional diagnosis in the form of a biopsy, and when exactly do you consider doing that in your patients?
So those patients who come in with either history of trauma or recent surgery, as in the cases that I showed to you, which were the cases with either Pseudomonas or thorn injury or a stick injury or mud falling into the eye. So these are all the classic trauma that the patient can have, which are associated with infectious cause, an outright suppurative kind of infection, either bacterial or fungal or nocardia and so on. So these patients, we definitely emphasize that the biopsy is the way to go. And also we need to localize, usually these patients have pockets of pus, and we need to open up the conjunctiva from the top and sort of remove these pockets of pus. Otherwise the antimicrobial agent won't reach that. We won't get a tissue diagnosis and we won't be able to institute therapy. So in our experience, if we are able to catch the infection early on, the resolution can be dramatic. So I guess we sort of convince the patient. The kind of patients that you're talking about, we have them too, where it looks just like immune-mediated scleritis. And that's the reason why we start them on steroids. They initially do well as you withdraw steroids. So for these patients, either we are looking at an infectious etiology. For example, it could be Mycobacterium tubercular kind of a scleritis, not the active infectious one, but the hypersensitivity kind of a scleritis, or it could be viral also, as in the example that I showed you. That example was easy because the patient had Ixero. Sometimes they might have old keratitis scars or some telltale signs. But in a particular patient like yours, and the last differential for that particular patient that you have and we also have would be that we'll start the patient on immunomodulators if you're very confident that it is immune mediated, and then see if that can take over the dependency on steroids. In between the two, somewhere sits in the viral diagnosis, where even if you don't have a clinical clue, but the fact that the patient every time relapses with steroids, I might start a course of antivirals. It's sort of empirical. So this patient, if that patient has a nodular lesion, this is exactly the patient you say, that I would try to offer scleral biopsy for tissue diagnosis. I could do PCR for virology, for mycobacterium, for these kind of patients.
Any other comments from anybody? Now, since we have missed intermediate uveitis, and it does form a very important clinical entity and a very, day-to-day practice, we see very often intermediate uveitis. I would just request Dr. Sudha Ganesh and Dr. Vishali if they could just give some tips for diagnosing and for managing intermediate uveitis.
Dr. Sudha.
In intermediate uveitis, most of the time the patients present with floaters. That's the complaint with which they come to the hospital. And most of the time, unless they have a spillover anterior uveitis, we find some cells in the anterior vitreous cavity, retrolental cells. And a fundus examination in these patients would reveal the presence of exudates over the pars plana, which may be either in form of membranes or small snowball kind of opacities which are floating around in the vitreous. And at times you may see an associated CME in these patients, disc hyperemia. Very rarely, very severe pars planitis, you can see a neovascularization of the pars plana membranes that you look at. And at times they may present even with a vitreous hemorrhage, where there is a bleed from these neovascular membranes on the pars plana. So here we generally start with the investigation as in any other uveitis, infected, non-infected, granulomatous. These are the etiologies that we would rule out, including a multiple sclerosis. And of course, I'm just recounting what I would do in the clinic because I'm not offhand prepared. So here we just try to treat the patient depending on the vision. Like if the patient has a very good visual acuity, we just give the patient, we can even watch the patient if the patient has a 6.5 N6. But if the patient has a CME, then it needs to be addressed. Not only with topical, we try to give periocular. And of course, if it's a very bad CME and OCT, we can even try anti-VEGF or the Ozurdex, which we give. Of course, when you look at the cause, you look at an infective cause. If it's associated with TB, we direct, in addition to the topical, periocular, and local steroids and systemic steroid therapy, we can add immunosuppressives if it's non-infective. And if it's infective, we treat the specific cause. Very rarely in children, you can see pars plana membranes in cases of toxocariasis, in which case we can give anti-helminthic therapy. And sometimes pars planitis, some of the complications in addition to the CME and the vitreous hemorrhage would not only be the cataracts, but it would also be a peripheral traction retinal detachment. And at times, as the inflammation resolves, you can look at peripheral scars, which can have small breaks, which may need to be treated. There was a time when they used to treat these pars plana lesions with cryotherapy or ILO, but I think of late we are not doing them. But I think we do the 4-step approach to therapy, which we used to call it as the Kaplan's approach. There are any additional points? And of course, multiple sclerosis needs to be ruled out. And in these cases, it would also be useful to get a wide field fundus fluorescein angiography to look at peripheral non-perfusions if there are any areas of peripheral vasculitis. And of course, in OCT to look at the posterior pole and closely monitor. And there are reports of having peripapillary neovascularizations in these cases of vasculinitis associated with vitritis. So depending on the clinical presentation, we need to treat these cases. Maybe Dr. Vaishali can add a few more points. I told whatever came to my mind.
I think Dr. Sudha has beautifully covered everything. I would just like to say a couple of points. One is the Fuchs uveitis many a times has these floaters or things in the vitreous, which are very much confused with intermediate uveitis, and patients started on immunosuppression. So if you have unilateral cataract and some KPs, and the vitreous is showing some lesions, but your fluorescein is not showing vascular leak. I mean, it's not really vasculitic kind of primary vasculitis that we see in intermediate uveitis. Always rule out Fuchs, because Fuchs tends to show a disc which is hyperfluorescent on fluorescein, floaters in the vitreous, cataract, no synecdoche, nothing. So that is one thing. The second, like Dr. Sudha said, children again need to be treated very aggressively, and many a times, if left untreated or half-heartedly treated, they will develop peripheral tractional detachment. So what happens is, like I had an experience, this girl who was under my management went to London, somebody saw her and they advised her retinal surgery. But if it's just a peripheral traction lying in the retina, I think it's important. I learned the lesson that if that child is moving elsewhere, the summary should also mention, instead of just saying it's sparse planitis, probably you need to mention that there is peripheral detachment or neovascularization, which needs to be kept under observation, because many a time some enthusiastic retina surgeon might end up doing cryos and, surgeries and creating even more mess than we already are. Rest everything Dr. Sudha has covered.
I'll now request Dr. Sudha to give her concluding remarks and sum up the entire session. Over to you, ma'am.
I think we had a very good session with Dr. Partho speaking about the anterior uveitis, where he covered most of the infectious and the non-infectious anterior uveitis. And of course, with the questions, we finished off with the post-operative anterior uveitis as well. And maybe one point that was missed there was, when you have a viral anterior uveitis, which Partho showed, you can also have a CMV anterior uveitis, especially in cases of Fuchs anterior uveitis. You may need to investigate some of these cases with an AC tab if they have associated trabeculitis, raised IOP, not responding to treatment. You have these coin-shaped KPs on confocal microscopy. So that was one point which was worth mentioning in the anterior uveitis, which Partho spoke about. The second talk by Dr. Reema was very well covered with choroiditis, talking about different phenotypes of retinitis, how you differentiate the two with OCT, and then the questions on CSCR and the exudative retinal inflammatory detachments, how you differentiate between the two. Maybe a small point on Bartonella, usually presents with associated neuroretinitis as well. I thought this could also be mentioned. And Dr. JB's talk on vasculitis was quite enlightening, where he told us that the prostate branch angiitis is not specific to CMV. It may be just a sign, and it may be because of any kind of an inflammation, be it infective or non-infective, and we need to find the cause. And the take home there was that we need to do an ultra wide field FFA to look at the vasculitis and the sequelae of vasculitis. And probably JB is doing an SSOCTA to look at the vasculitis pattern in his clinic of late. And of course, the next talk by Dr. Khosla on pediatric uveitis, the take-home point was aggressive management of the pediatric uveitis so that we don't end up with complications and amblyopia in these kids. And the most important thing is the management of complications in pediatric uveitis, which we all agreed upon. And of course, I think one more point that could have been mentioned was the TINO, tubercular interstitial nephritis, which is associated with uveitis in these children with proteinuria, which was one point that I thought could be mentioned. And of course, a little more, a few points on Blur syndrome, which Dr. Kalpana had also added. For Somshila's talk was excellent with the infective and the non-infective scleritis. And I thought the take home there was not to do a patch graft when there is an active inflammation or an infection. And that was very well managed. So I think overall the session has been quite useful, and thanks to all the speakers for helping us to do such a wonderful session, and thanks to DOS for having me here.
Thank you so much.
Very good afternoon to one and all. And on behalf of Delhi Ophthalmological Society, I thank all the speakers and welcome the delegates in this interesting session, which has been concluded. And I would like to thank Dr. Manisha, Dr. Jyotirmay Viswas, Dr. Vaishali, Dr. Nikhil Khatri, Dr. Amit Khosla, Dr. Rima Bansal, Dr. Sudha K. Ganesh, Dr. Kalpana. Thank you. Thank you very much.
Thank you so much. Since we have concluded the session way before time, wanted to know if we could wait one more minute and then get started. We have got the AV people who are going to give us the go-ahead for the next session to get started.
Our next session is at 5:30, no?
Yes. Oh, immediately you want to start with that? Just give us one more minute for the AV team to give.
That's okay, because you said way before, I thought.
Because normally we were expecting it to get early at exactly at 5:30. Normally it happens that it extends, but you guys made it sure that it goes on time, and the discussions went so well, there is nothing to be worried about.
In future, when you are dealing with Uveitis Society of India, you should mean business. Half an hour means half an hour.
मैम I'll be very honest with you, इतने सारे कॉन्फ्रेंसेस करते हैं और सब डिले होता है. ये पहली बार, मतलब जैसे आप सच में बता रहा हूँ, इतनी खुशी हो रही है कि आप टाइम पे खत्म कर रहे हो. So इसलिए we were not expecting.
We are very business-like people.
Yes, ma'am. In fact, कभी-कभी मुझे रोकना भी पड़ता है, but this conference I'm actually relaxed. I'm talking with my other hall people also simultaneously, and I'm having a smile because there's nothing to be worried about.
We could see you doing that.
Yes, I'm sorry. So I was talking to the other hall coordinators also, and we were just having such a smile. And the other halls are also going on time. So
good.
We are very happy, ma'am.
I just want to have the last word, and I want to thank each one of you for sending me your pre-recorded talks. I think that also really helped us to be on time, and we had some great discussion. And thank you once again. Thank you, JB sir, for joining all the way from Calcutta. And thank you, Dr. Sudha, for summing it up so well. So I would just hand over now to Dr. Rima to moderate the next session. And thank you, Vishali ma'am.
I think Dr. Biswas was in office. He looks like
he's in Calcutta.
No, I'm in Calcutta office.
Oh, okay.
I'm at Calcutta.
And will we be playing our pre-recorded talks for the session?
Yes.
Okay.
Yes, Mudit.
All right. Hello, ma'am. Hi, everyone.
Hi.
Hello, everyone. Just a quick question before we start. Do we have all the pre-recorded talks for the session?
Rima, we do have.
Yes,
all
ma'am.
We have? Okay.
Yes,
So we start only 5:33.
Dr. Sudarshan and Dr. Bala Murugan has not joined in. Are we waiting for them?
No, Sudarshan has joined. You have to bring him in the panelist. He's in the audience.
There's somebody called as Darshan in the waiting room.
Yeah, yes, that's. I have to get him in. He's Dr. Sudarshan.
So I just invited. So yes.
Hello.
Okay.
Good evening, everyone.
Good evening, ma'am.
Good evening. Yeah.
So I think now we can get started. So I'll just introduce the chairperson. And I believe it's 8 minutes, but I think again we're going to finish on time. So there's nothing to be worried again. Yesterday we had a very hard time, but today it's going to be going as smooth as butter.
Yesterday was 20 minutes late when I logged in.
Yes, ma'am. It was going crazy because there were 10 talks, 8 minutes each in 90 minutes. So it was just madness. Okay. So shall I invite the chairpersons and we get started? Atul, are we ready to go live itself?
Yes, please start.
Yes, okay. So we've got the chairpersons. I request Dr. Jyotirmay Biswas and Dr. Ratina ma'am to please unmute herself and also switch on the camera. We've also got the co-conveners. We've got Dr. Sudarshan who's joined us, Dr. S. Sudarshan. And we've also got the moderator, Dr. Rima Bansal, who's going to be taking the proceedings further. I request Dr. Rima Bansal to please unmute herself.
Rima.
Yes. Over to Dr. Rima.
So thank you, DOS, once again. And it's a pleasure to be moderating the second session of uveitis just before, after the first session, which was really great. And as you've already introduced the chair.
Is Rima frozen or is it everybody?
Rima side, ma'am.
Manisha, can you take over?
Yes, I will take over till Rima joins. Yeah, yes, Rima, please go ahead.
So welcome, Sudarshan. He's also in Dr. Biswas' team, a very senior consultant in UVA at Shankar Nethralaya. Bala is trained under Dr. Ratinam and he's heading the UVA services at Puducherry, and myself, Rima at PGI. So I would like to invite Dr. Vishali ma'am for her talk on ocular tuberculosis. So ma'am is heading the UVA and retina services at PGI. She's the president of USI. Over to you, ma'am.
I have been assigned a topic of intraocular tuberculosis. Now, I would briefly talk about when to suspect and when to treat intraocular tuberculosis on behalf of lots of societies and who gave us the opportunity to work together. There is a situation when you look at this man, 46-year-old, sudden visual loss, acute onset, non-granulomatous uveitis. Do not think of TB, even if the tests may be positive. On the other hand, you have a typical phenotype, granulomatous anterior uveitis with K-base, nodules, broad-based posterior synecdoche. Think of tuberculosis. And as per the consensus by Cox group, anti-TB drugs may be added if all the three tests are positive. However, if the episode is recurrent, then there is a very, very strong consensus to add anti-TB drugs. Sorry. In case just one or two tests are positive, we could not have the consensus to treat in the first episode, but in the recurrent episode, there was a moderate consensus to treat. When we talk of intermediate uveitis, TB uveitis typically presents as moderate to severe vitritis, large snowballs, and no snowbanking. There could be peripheral sheathing, there could be small patches of choroiditis and cystoid macular edema. Think of TB as a possibility. The treatment with TB is very successful. Many times like this, you can see below the response to anti-TB drugs. However, the literature shows that overall patients for intermediate uveitis who are treated for TB may not show a very good response. The success rate is not too high. Therefore, consensus to treat intermediate uveitis with anti-TB was if all the three tests were positive, if at least two tests were positive. But if only one test was positive and there is intermediate uveitis, there was not consensus to treat. But when we talk of pan-uveitis, again, if all the three tests were positive, there was a very strong consensus to treat. But if only two tests were positive, there was a moderate consensus to treat with anti-TB drugs. Talking of the tuberculomas, these are large, single, yellowish-white lobulated granulomas that may have a lot of vascularization. And the top panel shows a very typical classical tuberculoma compared to the bottom one, which shows sarcoid granulomas, which unlike TB granulomas are small and they are in the stroma. And tuberculoma, as you can see in the left, they are large and produce changes in the overlying outer retina, as is indicated by the arrowhead. Whereas sarcoid granulomas, as is seen here, are small, embedded in the stroma and multiple. When we talk of serpiginous-like choroiditis, it is multifocal variety of serpiginous choroiditis that is seen in tuberculosis, and it has some features which are very, very distinct from classical non-TB serpiginous choroiditis. The differences are serpiginous-like tubercular choroiditis tends to be unilateral, may have associated inflammation, usually begins in the posterior pole, multifocal, and then you have pigment clump in the center of the healed lesions. Now, when we talk of consensus to treat, serpiginous-like choroiditis is a phenotype which is very strongly associated with tuberculosis. So there was a very strong consensus to treat if all the three tests were positive, a very strong consensus to treat even if the two tests were positive, and coming to the endemic region, there was a consensus to treat even if there is just one test positive with serpiginous-like choroiditis. Granulomas, again, very strong consensus to treat because they are very typical for tubercular etiology if all the three or at least two tests are positive. However, granuloma is such a strong phenotype that even if there is one test of TB positive, there was a moderate consensus to treat. For multifocal choroiditis, there was a strong consensus to treat only when all the three tests were positive, because this is not a phenotype which is so very classical for TB. So to summarize, if when we talk of serpiginous choroiditis, the phenotype is so classical that if both the immunological tests are positive, that is PPD and ICRA, and one radiologic test, which could either be CT or X-ray positive, we would treat it. If just one immunological test is positive, which could be PPD and or ICRA, and radiology is either not done or not available, there is consensus to treat. One immunological test positive, which could either be PPD or ICRA, and the second is either not done, not available, and one radiology positive, we will treat. Just one immunological test positive, there is consensus to treat. When we come to anterior uveitis, the first episode we treat only if all the three tests are positive. If just two or one test is positive, we had a consensus to treat only the recurrent episode, not first episode. Inactive TB vasculitis, there was no consensus to treat and it should not be treated. But if it is occlusive active TB vasculitis, to be treated if all the three or at least two tests are positive. If for more information, both the papers are available in the Journal of Ophthalmology, about how and not how, about when to treat intraocular tuberculosis. Thank you very much for your patient hearing. Thank you.
Thank you, ma'am. So, do we have any questions? Dr. Biswas, would you like to add anything?
Sir, you are muted.
I just wanted to tell you that classic peripapillaris serpiginous choroiditis, do you treat in a different way than multifocal serpiginoid choroiditis or serpiginous-like choroiditis? So I have seen few cases, which is the classic serpiginous choroiditis, which is not very common in our country. Do you treat as a tubercular etiology also?
I agree.
This is for
I agree. I agree with Dr. Biswas that before you start thinking of testing for TB or treating for TB, first your clinical presentation has to be consistent with TB. So if you are seeing classical peripapillary variety, don't think of TB because that is not the feature of TB choroiditis. I agree.
Thank you, ma'am. Thank you, sir. So we move on to the next talk of this session by Dr. Kalpana Babu Murthy on viral posterior uveitis. Over to you, Kalpana.
At the outset, I thank the Uveitis Society of India for this invitation. Viral retinitis is a rare disease with a high rate of visual morbidity. The causative viruses belong to the family Herpes viridae. They are characterized by latency within the host cells after the primary infection. Depressed cell-mediated immunity can lead to reactivation and clinical disease, and the host immunity informs the spectrum of presentations. The diagnosis is usually clinical by pattern recognition, consisting of identifying the pattern of retinitis, presence of pigmented keratic precipitates across the entire endothelium, and increase in the intraocular pressure. Let us look at the patterns one by one. The first pattern is acute retinal necrosis. This is characterized by one or more foci of retinal necrosis in the peripheral retina with a circumferential spread and occlusive vasculopathy. Sometimes it can present initially as optic disc edema with subretinal fluid pockets, like in this case, which was mistaken for VKH and started on high doses of oral steroids, but developed acute retinal necrosis in 2 days. The fluorescent angiography pictures showing the necrotic areas and the vascular changes. ARN is usually caused by varicella zoster virus and the herpes simplex virus, and very rarely the cytomegalovirus. Immunocompetence is the traditional hallmark. In 50% cases, there is a history of herpetic infection. Immune dysfunction can also occur due to malignancies, presence of certain systemic diseases, and certain drugs. The treatment is intravenous acyclovir induction, followed by oral acyclovir for 6 to 12 weeks. Regression takes 2 to 4 weeks. Newer antivirals such as valcyclovir achieve good oral bioavailability. Systemic therapy is required to decrease the incidence of involvement of the other eye and prevent CNS manifestations. Intravitreal antiviral injections hasten resolution of retinitis, and oral steroids can be added with the antiviral cover to reduce the vitritis. These cases have to be monitored very closely for development of retinal breaks and retinal detachments. The next pattern is the progressive outer retinal necrosis, which is characterized by deep retinal opacification with perivenular lucency and absence of intraocular inflammation. This is usually seen in severe immune suppression, such as in HIV with very poor CD4 counts, and this is caused by varicella zoster virus in most of the cases. Treatment is aggressive intravenous and intravitreal antiviral therapy, especially ganciclovir, and at the same time, correction of underlying immune deficiency. These cases are associated with very poor prognosis due to the outer retinal atrophy. This is a rare case of bilateral outer retinal necrosis in a young girl following mumps infection, which resulted in outer retinal atrophy and only perception of light. The third pattern is the pizza pie and the tomato ketchup appearance, which is seen with cytomegalovirus retinitis. These retinitis can also be associated with frosted branch gingitis. Non-HIV causes of this kind of retinitis is also seen in post-transplants, biologics, malignancies, and local steroid injections. When we see more of the hemorrhagic component in CMV retinitis, it is important to rule out hematological abnormalities, as in this child who had very low hemoglobin. This is another child who presented initially with bilateral Fuchs heterochromic iridocyclitis with increased intraocular pressure with a peripheral vascular leakage on fluorescein angiogram. This patient was lost to follow-up, but was treated with oral steroids elsewhere, only to develop CMV retinitis a year later. Due to free availability of antiretroviral therapy, thanks to the National AIDS Control Program, immune recovery uveitis can present as vitritis, panuveitis, and arthritis. Arthritis, when present, requires systemic antiviral therapy. This is a case of bilateral arthritis, which progressed very fast to ischemia, and these cases require early laser photocoagulation. Unlike the HIV counterparts, CMV retinitis in non-HIV are generally refractory to treatment requiring multiple intravitreal injections and are usually associated with vasculopathy, ischemia, and neovascularization. Systemic treatment with intravenous ganciclovir or oral ganciclovir, along with intravitreal ganciclovir injections, are required for this kind of retinitis. And in those cases which are refractory to ganciclovir, you could give foscarnet or cidofovir. This is a case of CMV retinitis responding well to treatment with local injections, but developed arthritis requiring systemic antiviral therapy. And these cases need to be monitored very closely for ischemia and neovascularization. A few facts about acyclovir and ganciclovir. These drugs do not require test doses, as intradermal injections can cause tissue necrosis, as in this case. And it is important to note that these are vesicants, and therefore, while giving intravenous infusion, it is important to avoid subcutaneous extravasation, as this can cause tissue necrosis with extensive tissue damage. The fourth pattern is the multifocal retinitis, now coined as post-fever retinitis, as it can be seen post-dengue, chikungunya, West Nile virus, and most recently post-COVID infections. They generally present with very poor vision and extensive areas of neuroretinitis, but they generally are associated with good visual prognosis over a period of time, unless there is an associated vascular occlusion, as in this case. The diagnosis of viral retinitis is purely clinical, and labs are supportive to check for immune deficiency and for drug monitoring. PCR is useful in atypical cases and for monitoring therapy in cases of CMV retinitis. To conclude, viral retinitis is an ophthalmic emergency, and there is an increased incidence in the era of HIV and iatrogenic immune suppression. Cornerstones of management are early diagnosis, aggressive treatment, and multidisciplinary approach to manage the immune deficiency. I thank you all for a patient hearing.
Thank you, Dr. Kalpana. This was a very well covered topic with all these subheadings and absolute excellent flow. Before anybody has a question, I have a question for you, Kalpana. What is the regime you follow for viral anterior uveitis? Because there's a lot of confusion. You know, you want to give for 3 months, 6 months, and just go on and on. So anybody, this question is open to all the panelists. We start with Kalpana.
So viral anterior uveitis, unlike the posterior uveitis, generally we see in otherwise immune competent individuals. So there is either a history of herpes or there may not be a history of herpes. And nowadays we are picking up cytomegalovirus quite often. So generally, if it is herpetic related and if there is granulomatous inflammation, these cases definitely need oral valcyclovir for at least 3 months. And generally we kind of the hallmark is when you're seeing clinically, and if you see pigmentation on the endothelium, that means there is still inflammation which is still there, because that means the iris necrosis is still going on. because of the vasculitis. So it is important to keep these patients on oral antivirals for quite some time. CMV, again, there is a lot of talk on whether you need to give oral or just local medications. I generally do a specular and PACI in most cases of my CMV, anterior uveitis. If there is a reduction in the counts over a period of time, especially corneal endothelial counts, and if the intraocular pressure is becoming refractory to topical steroids and local antivirals, so this is a time when I start them on oral valganciclovir. The problem with CMV anterior uveitis is as long as they are on oral medications, they do very well. And the minute you take them off, again, it starts coming back. So generally, local therapy at least 5 times a day, 3 to 5 times a day has done very well in my hands. So I'm quite happy with this regimen. But definitely the pressures are very high. So there's a lot of trabeculitis which goes on in CMV-related uveitis. So these patients definitely need topical steroids to get the pressures down, along with antivirals, either local or thing. But herpetic, generally, they do very well, especially the zoster related, if they are treated very early. And I think the crucial part is within 1 year. If they are treated very well during that 1 year, then the chances of recurrences are very low.
So the question is, do you go on to give for 1 year?
So Asavir, herpetic, especially if there is a granulomatous, many of my patients have needed at least 3 to 6 months of valcyclovir, with of course constant monitoring of their blood urea and serum creatinine.
People 1 gram TID, BD, and then
Yeah,
OD,
and I generally keep them on 500 mg BD for some time, and then 500 mg once a day. And sometimes even we've had patients who've even had twice a week of 500 mg, and they come back immediately the minute you take them off. They come back with pigments on the endothelium. So I think my longest is, I think Dr. Sudha Ganesh and me share this patient, and it's about 8 years of valcyclovir.
Oh my God.
But I always had a doubt. Is it okay to reduce like this? I reduce exactly like Kalpana, TDS, BD, OD, 500, 250. But back of my mind, I always have a feeling in antibiotic, they develop resistance. In virus, we do not know. Is it okay to reduce, or should there be any basic research towards this question in future? Somebody, youngsters should take up that.
I think the basis, I mean, I totally agree with you, because some patients need 500 mg BD, some patients are very fine with 500 mg twice a week. I think the pathology which is happening in herpetic is there is a vasculitis which is going on in the iris vasculature. So there is a release of pigments. So when you see pigments on the endothelium, because if they're treated well, you just don't have any pigments on the endothelium. The minute the antivirals come down, you start seeing pigments on the endothelium, and within a fortnight, they develop increase in intraocular pressures. So I think there is an ongoing vasculitis which is still probably occurring in these cases, which warrants the need of antivirals. Unfortunately, many patients, again, if they don't take it properly or so, they'll end up with corneal issues, and then the whole thing gets messed up. And so that is a big problem. Yeah. As long as it's uveitis, we are happy, because they do very well with antivirals and topicals.
Uveitis, it's a fight between
once the cornea becomes involved, it's a headache. Yeah.
So, any comments from Bala?
What are the red flag signs in anterior uveitis?
For viral?
Yeah.
So viral, I think you will see pigmented keratic precipitates across the endothelium when the inflammation is still going on. The intraocular pressures can be high, and you will also see changes in the iris pigment epithelium. So you can have discrete lesions, you can have sectoral iris atrophies, sometimes you can have a moth-eaten kind of appearance. Very early, if you pick it up, you can see iridoparesis. And if you leave it like that, then they land up with sectoral iris atrophy at that area of paresis. So if you can treat these patients at this sign itself, if you can pick it up, they generally do well.
So thank you, Kalpana. And so we move on to the next talk on ocular syphilis by Dr. Mudit Tyagi. Mudit is a uveitis consultant and a retina surgeon at LV Prasad Institute, Hyderabad. Over to you, Mudit.
Good evening. First of all, let me thank the Uveitis Society of India, the Delhi Ophthalmic Society, and the organizers of this session, including Dr. Manisha, for giving me a chance to speak on ocular syphilis. So in the next few slides, I will be showing a few cases of syphilis and what can be the common patterns and how we can identify them and how do we go around treating ocular syphilis. So this was the first case of syphilis which we had seen way back in 2016. This was a gentleman who came to us with a decreased vision in the left eye in the last 2 weeks. And an examination revealed the presence of cystoid macular edema and nothing else apart from a few vitreous cells and CME and some occasional AC inflammation. And OCT showed the presence of cystoid macular edema, few cells in the vitreous interface. And when we investigated this patient, all the tests, including VDRL, came negative. So we thought we are dealing with a case of intermediate uveitis, gave the patient intravitreal Ozurdex since the patient did not want to take systemic steroids. And then 1 month later, patient comes with a further decrease in vision. And now we can appreciate this lesion over here around the macula and one patch of inferior retinitis. And we thought, are we dealing with probably a fungal endophthalmitis, which has happened post Ozurdex? Because at that point of time, we did not think of syphilis as one of the diagnoses. The VDRL test had come negative. And so we did not even entertain ocular syphilis as our initial diagnosis at that point of time. Some days later, the lesions progressed, this worsened still further. And now you can see these multiple miliary lesions over here in the inferior temporal quadrant, along with progress in the area of retinitis. And we can see this Ozurdex implant over here inferiorly. The patient lesions kept on increasing, the vision decreased, and now we can see this RP nodularity and photoreceptor changes also on OCT. So this is how the patient's lesions progressed. And subsequently now the patient's vision came down to 21-25, and it actually further went down to counting just 1 meter over the course of the next few days. And now we could see this area of a ground glass retinitis with central clearing and these multiple miliary lesions. And at this point of time, we were absolutely clueless as to what we were dealing with because we had not seen syphilis earlier. So we went back, and what do we do when you are in doubt? You go back and revise your history. So we went back and spoke to the patient again. And now the patient tells us that he had a genital lesion a year earlier, which dissolved by itself. And then we thought, are we dealing with a chancre? And so we got a TPHA done now, and the TPHA came positive. And then we realized we were dealing with a case of ocular syphilis to begin with. So the point to remember over here is that non-treponemal tests like VDRL and RPR are essentially used to monitor a response to treatment. So a 4-fold reduction in VDRL and RPR titer can be an indicator of a clinical cure. But to diagnose syphilis, I would recommend the best tests are the treponemal ones, including TPHA. And this is what we are talking about. TPHA has got a sensitivity and specificity in the high 90s for ocular syphilis, as compared to VDRL and RPR, which have only got a sensitivity around 70%. And therefore, all patients of uveitis should be diagnosed and should initially be tested with TPHA. And this is what we do in our uveitis clinic. Every single patient of mine who comes with uveitis gets a TPHA also done, because syphilis can be such a big masquerade. So coming back to this patient, we started this patient on IV penicillin, and the lesion started regressing, and within 1 week the visual acuity had improved to 20/60, and at the last follow-up the patient's visual acuity was 20/20, and the patient has maintained that vision now for the last 5 years. So systemic syphilis can be divided into primary, secondary, latent, and tertiary, and ocular syphilis, according to CDC guidelines, should be treated on the lines of neurosyphilis, meaning thereby like a tertiary syphilis. So syphilitic posterior placoid chorioretinitis has been described earlier also. And if you see a placoid chorioretinitis lesion, think of ocular syphilis as one of your differentials. But apart from that, ocular syphilis can present in any form, ranging from anterior uveitis to vitritis to posterior uveitis, retinitis, and even isolated granulomas. OCT usually in this placoid chorioretinitis shows these RP changes and photoreceptor changes. And I'll now come to our second case, and this was actually a classic placoid chorioretinitis, where you see this lesion over here with these small, probably lesions outside the margin of the main lesion. And this was a patient who had a decrease in vision in the last 1 week. Autofluorescence reveals the extent of the lesion still further. And when they tested the patient came positive for HIV as well as for TPHA, was started on penicillin. And you can see on this OCT again those characteristic photoreceptor changes which we had talked about just a few slides back. So within 1 week of starting penicillin, look at how the lesions have responded. This was how it was earlier, and this is how the lesions responded. And the patient's final visual acuity returned to 20/20 in both eyes. This is the third case who was initially thought of as a case of optic neuritis because of some disc hyperemia, and the patient received a posterior subtenon in the left eye. But 1 month later, the patient developed these multiple miliary lesions. And the patient's vision became no PL in the left eye and something around 2200 in the right eye. The patient OCT revealed these full thickness retinitis lesions, and this is something which we had reported earlier. Presence of miliary lesions with a full retinal involvement is a clue to a potential ocular syphilis infection. So this patient's TPHA came positive, was started on penicillin, and within 1 week, like it happened in the earlier two cases, the lesions started regressing. Patient's vision equal to 20/60 initially, and finally the patient vision was 20/40 and maintained at 20/40 in the right eye. So coming back, these are the patterns of syphilis which you should remember. Multiple miliary lesions like what you see in these two slides, a placoid chorioretinitis, and a ground glass retinitis with the central clearing. So if you see them, think of ocular syphilis as one of your differentials, and these patterns are pretty specific and characteristic of syphilitic lesions. When it comes to treatment, like I said earlier, is on lines of neurosyphilis. So 18 to 24 million units of crystalline penicillin G for 14 days. However, if your patient has got sensitivity or a reaction to penicillin and can't tolerate it, then IV ceftriaxone is also an option, and oral doxycycline if nothing else is available. So 200 milligrams of oral doxycycline for a month works equally well and has been shown to have a CNS penetration equal to penicillin in some places. Therefore, first line of treatment penicillin, if not IV Traxone, if nothing else is available, 200 milligram of doxycycline. Also remember that patients of syphilis, their partners have to be evaluated clinically and serologically. Steroids do have an adjuvant role when it comes to treatment in taking care of vitritis, but to be honest, we have now seen around 35 patients of syphilis, and in none of them a need to use steroids was there. All of them responded very well to IV penicillin. And now before I end, let me just show you two more cases. I've shown them earlier, but they are a representation of how big a masquerade syphilis can be. So this was a patient who presented to us with these healed lesions of choroiditis and these granulomas, which you can see superiorly as well as inferiorly. And an OCT revealed the presence of cystoid macular edema, and an OCT passing through the granuloma can easily help us in appreciating this choroidal granulomatous lesion over here. So looking at it, the patient's features were absolutely suggestive of ocular tuberculosis. Then in fact, even MON2 came 30 for this patient. But to our surprise, the TPH and VDRL were both positive. And so we treated this patient on lines of ocular syphilis. And just after 2 weeks of IV crystalline penicillin, to our surprise, all of the lesions had regressed and gone away. So the cystoid macular edema went away, the granuloma disappeared just with 2 weeks of penicillin. So this is how the patient was initially, and this is how the patient was after 2 weeks of penicillin. And this case again illustrates beautifully how much of a masquerade syphilis can be, and in what different manifestations it can be presenting in your clinic. So the point is, consider syphilis as a differential for every single uveitis case of yours. And the last case, this was a patient who was thought of as intermediate uveitis, was initially treated with IV methylprednisolone, then subsequently immunosuppression, and when the patient still did not improve, the treating physician ended up giving them Ozurdex. And at no point was this patient tested for syphilis, much to our dismay. And so when this patient came to our clinic, I saw this patient and I saw this multiple miliary lesions. And then we thought that is this syphilis instead of what has been treated earlier? And so we got the patient tested for TPHA. TPHA came positive. The patient's vision was counter fingers close to face at the time of presentation to our clinic. After starting penicillin, Vision finally improved to 20/60 in both the eyes. So the take-home message is ocular syphilis, if detected in time and treated early, has got a good visual outcome and good anatomical outcomes too. Treponema tests like TPHA should be done in all cases of uveitis. Seropositive patients of HIV should be screened for syphilis. And the treatment is in lines of neurosyphilis, so 18 to 24 million units of aqueous crystalline penicillin. Or if that's not available, then IV ceftriaxone or doxycycline should be your treatments of choice for syphilis. And with that, I would like to end this presentation and once again thank the organizers for giving me a chance.
One more question, Mudit. Is it crystalline penicillin available everywhere? Because in Tamil Nadu, we face the scarcity often, and we give procaine penicillin for 3 weeks. Is it crystalline penicillin available all over India?
It is available in most places, at least over here in Hyderabad. In our hospital, we did not ever face a difficulty in procuring it. But you are right, I have had some of my patients and some of my colleagues who have told me that they find it difficult sometimes to get hold of crystalline penicillin. In that case, like what infectious disease specialists do, you can give procaine penicillin also. But like I said, if nothing else is available, then doxycycline 200 milligram works equally well. In fact, there are papers which have shown that doxycycline has got equal CNS penetration, and people have used it even to treat neurosyphilis in penicillin allergic cases. So you are right. If nothing else is available, procaine penicillin does work. If even that is not available, then doxy or ceftriaxone.
Okay.
Even we have an issue in Karnataka. It's available only in Nimhans, and now there also it's not available. So now we are using just benzathine penicillin like once in 3 weeks. But the problem is that doesn't have much of a CNS penetration. So that is a big issue for us.
So ma'am, doxycycline can be a very good alternative.
We give both, yeah.
So Mudit,
Just want to make a comment.
Yes.
I don't do syphilis test for all cases. For example, if I see an unequivocal case of VKH, sympathetic ophthalmia, I don't order for syphilis test. Or is a kind of a recurrent non-granulomatous anterior uveitis with fibrin. I don't order syphilis test. I just judiciously use it. And if I'm not sure about the diagnosis of any case, I do the syphilis test for first time, particularly treponemal test.
I would just like to ask a question to Mudit. Many times when we do the test, we've had patients who come out positive for TPHA or VDRL, or predominantly TPHA. And these patients require immunomodulators. So do you treat these patients with doxy or anything, and then you add because they may be two different entities. I mean, it may not be related.
As in, are we talking about false positivity of TPHA?
No. Yeah, false positivity, or generally when we are doing the tests, we also check for VDRL and TPHA in many cases.
No, if it is a false positivity, and we have had actually 2 cases which turned out to be actually false positive. We got a TPHA positive, but it was not fitting into any of the clinical patterns. So then we got it tested from a repeat lab, and that came negative. And then we discounted that and we continued with the primary treatment. But I have never had a patient where I had a need of using immunomodulators along with a concurrent syphilitic pathology. So sometimes if you have a doubt, we have had those patients retested, and you need to just carefully monitor them and follow them again. And then if needed, then you can change your diagnosis and proceed as per the clinical presentation like what it is.
So Mudit, do you advise that they don't need steroids at all?
Well, I have honestly never used steroids in any of my cases, in none of them. And every single one of them, I know there are people who use steroids, and there are people who have said that vitritis, if there does respond very well to steroid, and you may need to use steroids for that vitritis, which can sometimes occur. But honestly, I have never had to resort to steroids in any of those cases. I am not discounting it. I would suggest that for any disease, I'm sorry.
Sorry. What about recurrences? I mean, how do they score over a period of
So
time?
we have had 2 patients of recurrences. In them, they were initially given penicillin, came back with a recurrence. We treated them with doxycycline actually the second time, because this time the patient was not willing to stay back for 14 days of penicillin. But then after that, they did not come back with a recurrence. I beg your pardon.
Doxy without steroids?
without steroids. Yeah.
Seema, I would just like to add one similar what you're saying, like, those kind of repeated vitritis sometimes you do see in HIV related patients. And what we have seen is sometimes they become refractory to therapy with penicillin. So these are, if you see their RPR titers, they're high. So these patients, I think the infectious disease person gives benzathine penicillin, I think once a month or something like that. So generally, even as what Mudit said, we've not used steroids, but we have checked the repeat RPR titers in these cases and kind of continued them on penicillin for quite some time.
The other point here, ma'am, is that we have to differentiate, are we dealing in those seropositive cases with the syphilis recurrence, or is it an immune recovery uveitis, which you probably are dealing with? Because if you are seeing a vitritis in those cases, that may just be a immune recovery uveitis rather than a recurrence of syphilis also sometimes.
So do you check, each time do you check the titer in your cases?
No, unless and until the patient comes back with new lesions, I don't usually get a titer check rate. Though ideally, there are times when people say that you should get a titer check. We initially check the titer post the treatment. We use VDRL as a marker for how much of the titers are changing as a response to treatment. But routinely on all visits, or if the patient comes back, we don't get a titer check.
I've had one occasion, Mudit, where the patient was on treatment for ocular syphilis, but also had optic nerve involvement.
Okay, yeah.
That's one situation where it was mutually decided that we will continue with the oral steroids after having given enough coverage with penicillin. And I think that helped the patient in better visual recovery when we started the patient on steroids.
No, that is absolutely correct, ma'am. You are right. In cases of optic nerve involvement, I think steroids are necessary. We never actually came across such a patient, but you are absolutely right. If there is a nerve involvement, you will have to give steroids. And the thing about steroids is they can be very useful in taking care of inflammation. The only point we have to remember is that they should be started under an appropriate antimicrobial cover. So if they are under cover of penicillin, I think that's perfectly well justified, and that was needed also. Yeah.
We had a couple of cases who showed paradoxical worsening of inflammation following antisyphilitic treatment due to Zale's eczema reaction, what we see in systemic manifestations. Those patients responded well to steroid therapy under cover of antimicrobial therapy.
Yeah.
Thank you, Padma, and thank you, Mudit. I think we need to move fast. We are having a lot of discussion. We now move to the next speaker, Dr. Sudarshan, who's also our co-convener. We'll be talking on uveitis in HIV, and he has a vast experience on HIV patients having uveitis, and he's published extensively on it. Over to you, Sudarshan.
Hello, everyone. Thanks, Manisha and the DOS organizing team for giving me the opportunity. So, continuing with our infection and inflammation. So, let's move on to ocular inflammation in HIV and AIDS patients. So, before actually treating the patients with ocular inflammation in HIV, we need to actually know the systemic immune status of the patient, such as the CD4 counts, viral loads, because this will give us a clue to diagnose the ocular opportunistic infection. We can investigate accordingly and treat accordingly. So HIV and HIV-related intraocular inflammation can be because of HIV itself, or because of immune recovery uveitis or drug-induced ones. There can be some group of ocular inflammation which may not be directly attributable to HIV. So let's see each of them. So ocular opportunistic infection, the most classical one is this hemorrhagic retinitis, which was seen in this patient, a middle-aged male who came to us with vision loss for 1 week. This was a patient who was an irregular heart and low CD4 counts. So this is a classical presentation of CMV retinitis. A classical CMV retinitis, when you make a diagnosis, you need to treat right away with systemic valganciclovir and intravitreal. That's what we did in this patient. And this was a response, dramatic. So remember that these are systemic diseases and the manifestation is in the eye. So you need to treat them systemically. You can actually augment them with intravitreal, ganciclovir, and other intravitreal drugs, but that shouldn't be the monotherapy. Remember that diffuse retinitis with hemorrhages can be CMV, can also be atypical toxo. But one important thing that we need to remember in the current era is if you have a presentation like this with some placoid lesions. This was a patient where we did blood tests and they came out to be syphilitic positive. So syphilis is a diagnosis by exclusion. We had a large series of ocular syphilis in patients with HIV, where panuveitis was the commonest. Interestingly, in our series, we found that necrotizing retinitis mimicking CMV or toxo was seen in low CD4 counts, but the classical description of a placoid chorioretinitis was actually seen in higher CD4 counts. So MSM group of people are at higher risk of syphilis. CMV and VZV presenting as PORN can be seen in low CD4 counts, but TB, toxo, or syphilis can have presentations across the spectrum of CD4 counts. So they can be seen even in moderate or higher CD4 counts. The ocular response actually depends on the systemic status of the patient and how regular the patient is on heart. So we need to actually look for diseases which have similar risk factors. For example, a patient with syphilis may have similar sexual habits, and this can be a co-risk factor for both syphilis and HIV, or a patient with drug abuse can have some fungal infections. But remember that classical presentations of these infective lesions, the diagnosis is most of them clinical. But when it is atypical or when there are multiple like this, for example, this patient who came to us with multiple lesions like this, he was an irregular heart with very low CD4 counts, had a retinitis and had a choroidal granuloma also. So this was a combined infection of both CMV retinitis and tuberculoma. This patient passed away within a week of presentation to us. So it means that it's very important to identify them early and then treat all of these infections, not only for deciding the final visual outcome, because they can be an indicator of a severe risk of systemic mortality. So almost always remember that classical infective lesions are diagnosed clinically, but when in doubt, intraocular fluid evaluation for PCR and antibodies can help you confirm the diagnosis. Among the anterior segment lesions, the more important ones are the ocular adnexal complications and OSSN, because they can be life-threatening also, and they can be a sign of severe systemic immunosuppression. One common thing which we see is herpes zoster ophthalmicus. Any young patient with HZO suspect HIV. Herpetic lesions present with anterior segment lesions when the patient has higher CD4 counts, while with lower CD4 counts, herpes presents posteriorly. The relatively benign one among all these is the HIV retinopathy, presenting with corneal spots. They can have endothelitis, systemic endothelitis, and can have multiple infarcts in the brain. So it's not just that benign, but those are uncommon lesions. They can also be precursors for granular CMV retinitis, like in this patient. So periodic fundus evaluation is a must. Intraocular inflammation in HIV can be attributable to HIV or can be because of drug-related or drug-induced ones. Immune recovery uveitis is the most important one among them. This is a typical presentation of a CMV retinitis with low CD4 counts, but when it resolves with ganciclovir and heart, they come back with significant inflammation if the CD4 counts improve. So IRU can present with all inflammation-related complications like CME, ERM, or vitreomacular traction. So they need to be treated with low-dose, short-course, or monitored corticosteroids. It's very, very important to rule out infections before making a diagnosis of immune recovery uveitis. Drugs used in the treatment of the systemic disease, along with the HIV, such as for mycobacteria, rifabutin can cause hypopyon. Because any hypopyon in immunocompromised patients, we need to rule out endophthalmitis or PANOF or any other infective lesion. But remember, drugs can also cause them. Nevirapine can cause Stevens-Johnson-like syndrome. But the interesting thing nowadays is the retinal toxicity because of these ERT drugs. We published a series of efavirenz-associated retinal toxicity presenting with night vision defects in patients with HIV. This is one patient who was an efavirenz and came with night blindness. So after the efavirenz was changed, the ERG reverted to normal. So that is an interesting observation. And it's important for us to know the drug regime which is used in each particular patient. Intraocular inflammation in HIV can be because of HIV or drug-induced or immune recovery, but some uveitic conditions which are seen in non-HIV patients such as VKH can also be seen in HIV patients. This was a patient with moderate CD4 counts who came with VKH and secondary glaucoma. This was probably a coincidental condition, but this is just to reinforce the fact that with ERT and immunity being better in such patients, they can also present with immune-based diseases, even though they are supposedly immunocompromised. So to conclude, when you look for an algorithm, you remember that the basic one is to know the systemic HIV-related inflammation, based on which we can identify the OI. So look for newer manifestations with change in ERT or CD4 counts and treat them accordingly. So identifying immune recovery uveitis and ruling out other infection is very important. Drugs can also cause vision-threatening side effects. And remember that supposedly non-HIV uveitis conditions can also occur in HIV individuals. Thank you.
Thank you, Sudarshan, for a very wonderful coverage of uveitis in HIV. I think we'll take up some discussion at the end because we'll see how much time we are left with. So we move on to we'll note down the questions for you and we move on to the next topic of this session. The talk is by Dr. Balamurugan, who's from Puducherry, and he'll be talking on ocular toxoplasmosis. Over to you, Bala.
At the outset, I would like to thank Dr. Manisha for giving me this wonderful opportunity to present this topic on algorithmic approach to ocular toxoplasmosis. Basically, most of us know how to distinguish retinitis from choroiditis based on color, margin, presence or absence of vitritis, associated subretinal edema, and the various etiologies. And once we know it is retinitis, find out whether it is focal, multifocal, or diffuse. The focal could be because of toxo or candida. Multifocal could be toxo immunosuppressed or a Behçet's situation. Diffuse could be in an acute condition like ARN, subacute condition because of CMV or syphilis. Occlusive, we need to think in terms of inflammatory and non-inflammatory conditions. The non-inflammatory conditions could include hypertensive choroidopathy, hemoglobinopathy, and hyperviscosity syndromes. This was a 40-year-old gentleman presented with no contact threats. And as you see, there is a retinitis with no choroidal scar, vision of 6/12. And we ordered the toxo test. It was all negative. And then proceeded to AZTAP. And the IgG was positive, PCR was negative, and started with anti-toxo treatment. And you see the brilliant response to treatment helped us to proceed further. And with the course of anti-toxo for 4 to 6 weeks, there was a remarkable improvement. Toxoplasma can masquerade as acute retinal necrosis also. The trick to differentiate is in the OCT showing inner retinal hyperreflectivity with shadowing of the outer retina and the choroid. So this was a beautiful article which was depicted in the diagnosis dilemmas in retinitis in the endophthalmic. Coming on to the investigations, we have a set of serological tests and the imaging tests. Serological tests include, apart from the toxo titers, Savin-Feldman, PCR, and the Goldman-Whitford coefficient, and the miscellaneous. And the imaging tests, we all know, apart from OCT, B-scan, autofluorescence, FFA, we need to be a strong clinician to correlate all these findings together. The OCT findings of toxoplasma are really interesting. As you see, there is on the VR interface, in an untreated toxoplasma, we have a lot of inflammatory cells. So, based on the OCT, there are a lot of pointers to differential like ARN, CME, and the epidemic retinitis, which was published in the Uveitis Society of India newsletter by Dr. Padma Maran. There is also a choroidal elevation that we should never forget as well in toxoplasma. How is toxo different? If you carefully look, there is a full thickness retinal involvement with tissue loss and acute retinal necrosis, whereas in fungal endophthalmitis, there is choroidal and outer retinal involvement. When it is predominantly inner retinal involvement, you think in terms of epidemic or post-fever retinitis. As we know, TB can have a choroidal elevation, Haller-Sattel layer can help us as an additional pointer as well. So the beauty of toxoplasma is in the resolution pattern. So there could be a healing with pigmentation in the other time passes, and the pattern of healing is clearly described as centripetal clearing, which we need to really pay attention during the course of the disease. Okay. The serial follow-up of OCT is also useful to assess the dynamic change or progression of the disease. So, as you see, the various OCT signs are detailed here. There is detachment of the highlight and the cellular infiltration. There could be the stalagmite collection of the inflammatory deposits of the VR surfaces, intraretinal edema or fluid, choroidal thickening, which are elegantly captured. The various treatments for ocular toxoplasma include pyrimethamine sulfadiazine, cotrimoxazole, clindamycin, pyrimethamine sulfadiazine combination in as well as vitreal clindamycin and dexamethasone popularization. So helinetal, pyrimethamine, azithromycin, and trimethoprim sulfamethoxazole is definitely useful as a prophylaxis. For pregnancy, 6 months prior to conception or up to 18 weeks, spiramycin is considered useful. However, more than 18 weeks or later, pyrimethamine, sulfadiazine, and folic acid were considered. So the intravitreal therapy seems to be a buzzword these days, and the dosage is very important. It's 1 milligram with 400 microgram of dexamethasone. Maybe effective as triple therapy, preferred in recurrent infection pregnancy, not used in isolation. Because steroids like triamcinolone should be avoided to prevent uncontrolled progression of the disease. Is there any RCT? Yes. There is an RCT comparing the intravitreal clindamycin versus plus dexa combination with the oral therapy, and there are various pros and cons. That pros could be the similar efficacy, convenience, better alternative for pregnancy. The cons is that possibility of reinfection and its potential complications. So when there is a systemic problem, we need to definitely start with the systemic therapy. How to prevent recurrence? Half the dose of bacteremia every 3 days for 6 to 12 months was initially published. Look at the year 2002, American Journal of Ophthalmology, they published. But there is a recent article last year by the same group, and they said the long-term results are promising till 6 years. These are two interesting algorithms which are already published, stating the useful of the Goldman-Whitmer coefficient and the PCR at appropriate condition when the lesions are atypical and the vision is at risk. However, not many of us do the Goldman-Whitmer. So we mostly do the basic serological test as well as the PCR, and this is a beautiful flowchart telling that when it is atypical, go ahead with serology and acostomer sampling. Depending on the immunocompetent or immunosuppressed, you decide to do PCR and decide on further workup. This is a basic thing to understand that immunosuppressed, your serum IgM levels are not recommended, whereas serum IgG levels are considered important. Whereas immunocompetent Goldman-Whitmer as well as IgG, IgM are useful. PCR is useful in both immunocompetent as well as the suppressed. This is neatly eluded by the recent developments in diagnostic treatment of ocular toxoplasma. So the last but not the least, the buzzword now is artificial intelligence in the diagnosis of toxoplasma being popularized by standardized uveitis nomenclature SUN2. And they are validated using these criteria. These criteria are really useful for research purpose and not for practicing ophthalmologists. Need to really be careful on that. The criteria of number 1 is focal or quasi-focal necrosis in retinitis and evidence of infection of toxo by either positive PCR from Arcus arbitraris or positive serum IgM antibodies against toxo, or it could be a characteristic clinical features with hyperpigmented or atrophic scar, round or oval retinitis or recurrent episodes. Exclusions could be both are negative, IgM and IgG. Positive serology for syphilis or when this PCR for other viruses are coming out to be positive. A lot of this exclusion criteria, many of the clinicians may find it very tough to follow in the real-time practice. And thank you for the wonderful opportunity. Have a great day.
So thank you, Bala, for extensive coverage of ocular toxoplasmosis. So we now move on to the next talk by Dr. Manisha Agarwal on masquerades in uveitis. And Manisha, of course, needs no introduction. She's heading the vitreoretina and uveitis services at Shroff Charity Eye Hospital. Over to you, Manisha.
Thank you, Rima. Thank you, USI, for giving me this opportunity. I would be speaking on masquerades. So what do we mean by masquerades? Masquerades is a malignant process that basically simulates a benign condition. And I would explain this through a few case examples. My first case is a 3-year-old girl child who presented with pain and redness in the left eye for last 4 months, being treated with topical steroids and diagnosed to have anterior uveitis. She had already developed secondary glaucoma and was already onto anti-glaucoma medications. On examination, the child fixed and followed light The left eye showed a mild conjunctival congestion with fluffy white exudates in the anterior chamber. Her fundus appeared to be normal, and ultrasound B scan also appeared to be normal. So this is how her fundus of both the eyes they appeared. She was planned for examination under anesthesia, which showed that the ciliary processes were studied with white fluffy material, 360 degrees. An AC tap was planned with a long intracorneal track using a 30 gauge needle to avoid any kind of metastasis. And she was clinically diagnosed to have a retinoblastoma. Histopathology was done of the enucleated eyeball, and a gross pathology of the globe showed fluffy white material involving the ciliary body, the lens annules, and the anterior vitreous. However, there was no invasion of the optic nerve free end, and it was found to be free from the tumor cells. Cytopathology also was conclusive of retinoblastoma, and she was evaluated for any kind of metastasis by an ultrasound of the abdomen and MRI of the brain, which were found to be within normal. So no further investigation or intervention was planned for this child because she had no high-risk features, because the optic nerve and the choroid were found to be free of the tumor cells on histopathology. She was evaluated by a pediatric oncologist, and the final diagnosis of a diffuse anterior retinoblastoma was made in this child. So diffuse anterior retinoblastoma are usually sporadic tumors. They usually are unilateral and have a very slow progression with poor response to conservative therapy. The average age of presentation is about 6 years, and what is atypical is that they don't show any evidence of calcification of an ultrasound B scan, which is very typical of the diagnosis of a retinoblastoma. What is also atypical is that usually the foci of the tumor is in the retina, but in these tumors, it is a microscopic foci which is found in the retina, which often can be missed and creating a diagnostic dilemma. So the lessons learned from this case is it is a young child with unusual fluffy white exudates in the anterior chamber, not responding to the treatment of uveitis in the form of steroids for last 4 months, and that is something very unusual. Developing complications while being on long-term steroids in the form of glaucoma, and this is now a time to diagnose this patient either through an examination under anesthesia with interventional diagnosis, or to take another opinion by another colleague of yours. My second case is a 72-year-old male patient with diminution of vision in the right eye for last 3 months, having a history of non-Hodgkin's lymphoma, but in the remission phase, diagnosed with uveitis and vitritis, and on treatment with topical and oral corticosteroids for last 3 months, but the vitritis seemed to be not responding to the treatment. When we did a fundus examination, there was vitreous haze in both the eyes, and the vision was 6/9/N9 in the right eye with a vision of 6/6/N6 in the left eye. The uveitic profile seemed to be quite normal in this patient. There was a very subtle white lesion which could be appreciated along the inferotemporal arcade through the vitreous haze. The OCT through this lesion showed a sub-RPE deposit. The patient underwent a diagnostic vitrectomy after stopping oral steroids for 2 weeks. The vitreous sample taken was sent for cytology and immunohistochemistry. However, there was evidence only of a chronic or acute non-specific inflammatory reaction with no evidence of malignant cells which was found on any of the investigations. A systemic evaluation with a PET scan also showed that there was absolutely no evidence of any malignancy found in the body. After 2 weeks of the core vitrectomy, this lesion in the right eye appeared to enlarge in the size, and the left eye showed multiple lesions, again resembling the right eye lesion. The OCT showed the sub-RPE deposit in both the eyes, which was very much suggestive of an intraocular lymphoma. This is the fundus fluorescein angiography, which showed a diffuse hyperfluorescence in the area of the lesion in both the eyes. A left eye core vitrectomy was also done, and the sample was again sent, but it was again showing no evidence of any malignant cells. Based on the clinical suspicion, the patient underwent 2 injections of methotrexate in both the eyes. This is the timeline of the right eye, which showed the vitreous haze at the time of presentation. and there was evidence of enlargement of the lesion after 2 weeks of observation. However, following 2 injections of methotrexate, the lesion had completely melted away in the right eye. This is the timeline again of the left eye, which showed the appearance of fresh multiple lesions in the left eye after 2 weeks. However, after 2 injections of intravitreal methotrexate, all the lesions again had completely melted away on observing 20 days after the injections of the methotrexate. On follow-up, the patient was diagnosed as a patient having intraocular lymphoma in both the eyes, secondary to the systemic B-cell lymphoma. No new lesions were observed to occur in both the eyes on 6 months of observation after having undergone the treatment. The patient was referred back to the treating oncologist for a re-evaluation. However, there was no evidence of a reactivation of the systemic non-Hodgkin's lymphoma. So there is a term known as secondary intraocular lymphomas, which are very typically seen in older patients, and they very often have a history of systemic lymphoma, though the intraocular disease may be the initial presentation in such patients. The patients may present with lymphomatous uveal infiltrate several months following successful treatment of the systemic lymphoma. And at this stage, there may absolutely be no evidence of systemic disease, despite an extensive systemic or a clinical evaluation and a laboratory investigation, like in our patient. So the lessons learned is that here we are dealing with an elderly gentleman who's unlikely to have the first episode of uveitis at such an old age, not responding to any treatment of vitritis in the form of oral and topical steroids for last 1 month, again is very unusual and should raise an alarm. The clinical suspicion should always take precedence over all kinds of lab investigations, like in our patient again. And a detailed history taking is of utmost importance to rule out any kind of a masquerade. So a logarithmic approach to masquerade would be any patient belonging to extremes of age, we must suspect masquerade, unusual or an atypical clinical presentation, not responding to the usual standard of care, and routine investigations usually are not conclusive, and they may require specific investigation to rule out any underlying pathology. So I would just conclude my talk by saying that eyes are useless when the mind is blind, and always listen to your heart, even though it may be on your left, but it is always right. So thank you once again for this opportunity.
Thank you, Manisha. Very interesting cases. So we now move on to the last talk before we have the concluding remarks. COVID-19 and uveitis, I would say the most recent topic in uveitis. We have from Dr. Padma Malini Mahendradas. She's heading the uveitis services at Narayana Nethralaya, Bangalore.
Dr. Rima, thank you, Dr. Rima. I would like to thank Dr. Manisha, Uveitis Society of India, and all of you, and Dr. Rima and all of you for fantastic talks and for showcasing your session in our conference, which has, really elevated our scientific, you can say, sessions caliber. So thank you so much for sparing your time and for your contributions. Thank you, Manisha, and we for coordinating it.
Yeah, we thank you. We thank you for giving us, and it is wonderful to be with you people, because retina and DVI were so separate. Now we are coming closer, and it is augmenting each other's capacity, and it is wonderful to be with you. Thank you for this opportunity.
Thank you so much.
Thank you, Namrata ma'am. And I really appreciate that you have dedicated full 1 day for a UVA subspecialty day. That means a lot to our society.
Thank you so much. Thank you, Manisha.
Thank you, ma'am. So, Padma, can we have you?
Sure. Good evening to all of you. At the outset, I would like to thank Delhi Ophthalmic Society and also Uveitis Society of India for inviting me here today to speak on COVID-19 and uveitis. The next 8 minutes also, I'll be talking to you regarding about the COVID-19 disease and its uveitic association, pathogenesis of the disease with our case examples. Lastly, COVID-19 vaccine-associated uveitis. SARS-CoV-2 is a novel enveloped positive single-stranded RNA belonging to the Coronaviridae family. It is associated with atypical pneumonia and acute respiratory distress syndrome. The recent studies revealed the presence of COVID-19 virus in the conjunctival secretions and tears and also from the vitreous cavity. COVID-19 and uveitis have varied manifestations ranging from anterior uveitis to panuveitis, neuroretinitis, acute macular neuroretinopathy. The characteristic feature of COVID-19 uveitis is retinal vascular occlusions and association with uveitis, subeugenitis choroiditis, endogenous endophthalmitis, and recently SARS-CoV-2 retinitis also have been reported. Coming to the pathogenesis, the ACE2 receptor and protease enzymes play a key role in the pathogenesis of the disease. SARS-CoV-2 enters the cells by binding to ACE2 receptors, which is present on the surface of the host cell, inducing pyroptosis, a highly inflammatory form of cell death due to infection or intracellular pathogens. ACE2 expressed in various tissues, including the eye, they are present in the blood vessels, conjunctiva, cornea, and in the retina, mostly in the inner nuclear layer. Coming to the hypercoagulation in association with COVID, we have increased inflammatory markers, which causes endothelitis, and complement activation results in activation of the extensive coagulation pathway, platelet activations, and clot formation, which also through ACE2 receptors can result in hypercoagulable state. Whenever we see a patient with COVID-19 and uveitis, we need to see what phase of the disease we are seeing. If it is an infective stage where there is RT-PCR is positive, we need to treat them with antiviral therapy. If the patient as seen commonly in an inflammatory phase with increased inflammatory markers, we treat them with anti-inflammatory therapy, mostly with corticosteroids. If it's associated with hypercoagulable state, we treat them with anticoagulants in addition to anti-inflammatory therapy. Following COVID, we are seeing most late onset secondary infections. COVID-19 is treated with high dose of steroids and tocilizumab, and patients do develop de novo diabetes, can result in late manifestations of various infections, including bacterial and fungal. In that situations, we do treat them with antimicrobial therapy. Let's see our case examples. A 66-year male presented with sudden blurring of vision with previous history of fever and myalgia, was treated with systemic steroids and remdesivir, presented to my colleague Dr. Sanjay, had anterior segment inflammation and RAPD in the right eye. Fundus revealed retinal whitening in the posterior pole, temporal to the disc, with blood segmentation, cotton wool spots, hemorrhages, and hyperemia of the disc. In the left eye also, we could see hyperemia of the disc with cotton wool spots. This particular patient had increased inflammatory markers. Diagnosis of bilateral panuveitis with central retinal artery occlusion was made, and this patient was treated appropriately. This we have published in Ocular Immunology and Inflammation as post-COVID ophthalmic manifestations in Asian Indian male. The second case is a 54-year male, known case of diabetes on oral hypoglycemic agents with history of COVID positive, and he was also treated with remdesivir and tocilizumab. 2 months later, when the patient presented to a primary ophthalmologist, was diagnosed of intermediate uveitis. Most of the investigations were within normal limits. He was started on systemic steroids. Since the patient did not improve, he was referred to us for second opinion. Right eye was normal. The left eye revealed pigmented keratic precipitates with prominent corneal nerves. On this examination, we could see the hyperemia of the disc, vitreous ACEs 2+ with multiple opacities, snowball-like opacities. On investigation, AC tap is negative. However, the vitreous tap came positive for panfungal genome. The culture revealed Candida tropicalis from the vitreous. Patient underwent pars plana vitrectomy. Following topical intravitreal systemic antifungal therapy, we could see the complete resolution of inflammation in this case. Next case is a 49-year female presented to us November 2020 with a history of eye pain and loss of vision. Visual acuity was counting finger 2 meters. On examination, she had erythema multiforme like skin lesions in the extremities. Fundus examination showed retinal hemorrhages and retinitis lesions in the right eye, left eye vitreous hemorrhage, retinitis with opacification in the macula of the left eye. OCT showed hyperreflectivity with after shadowing in both eyes. FFA and ICG showed block fluorescence corresponding to retinitis and retinal hemorrhages with staining of the vessels. In the left eye, we could see the non-perfusion in the macula due to vessel occlusion. This is the timeline of the event. Patient had fever. CT was normal, so was managed symptomatically by the patient's relative, who was a doctor. Subsequently, patient presented with blurring of vision after 3 weeks. At this point of time, SARS-CoV-2 antibodies was positive. Chikungunya also came positive, and systemic steroids was started by the primary ophthalmologist. Subsequently, patient had further drop in vision. At this point, patient was referred to us. On evaluation, RT-PCR for SARS-CoV-2 and chikungunya were negative. Increased D-dimers were noted. Patient was put on intravenous enoxaparin followed by oral aspirin. Doxycycline was added, continuation of the systemic steroids, which resulted in improvement in the vision. Skin lesions decreased. On follow-up, only the SARS-CoV-2 antibodies were persisting with the disappearance of other viral antibodies. This is resolving retinitis lesions, and we could see the resolving skin lesions as well. So we reported this case as a bilateral post-severe retinitis with retinal vascular occlusions following SARS-CoV-2 infection in ocular immunology and inflammation. We are seeing more number of vaccine-triggered inflammation post-COVID-19 vaccination. It triggers both autoimmune as well as underlying infective etiology. Here we have episcleritis, nodular scleritis, and anterior uveitis. This is reactivation in a case of an HLA-B27 associated uveitis. 71-year gentleman presented with redness and pain. 10 days prior to the presentation, he has received the first dose on vaccine. Patient took the teleconsultation. Subsequently, the base hospital referral, we diagnosed it as a case of ARN. Visual acuity was counting finger 1 meter. ACTAP revealed positive for varicella zoster virus. Patient responded well to systemic antiviral and also systemic anti-inflammatory therapy. Resulted in resolution of the retinitis with atrophic retina. Reactivation of varicella zoster infection presenting as acute retinal necrosis following post-COVID vaccination has been accepted for publications in European Journal of Ophthalmology. We are anticipating a third wave where more and more pediatric cases are going to get affected. So multi-inflammatory syndrome, MIS, in children is important. They mimic Kawasaki disease, can cause bilateral uveitis associated with increased COVID antibodies. These cases are treated with intravenous immunoglobulin and oral steroids. To conclude, ocular manifestations can develop at any stage of the disease. Most commonly, we are seeing due to immune-mediated disease, or in late phases, secondary infections are also common. Patients should be warned about possible ophthalmic sequelae even after recovery from the COVID-19 infection or after COVID-19 vaccination. I would like to acknowledge my colleagues' contribution. Thank you for your patience listening.
Thank you so much, Padma. Wonderful cases, and now we see the spectrum of COVID-19 uveitis is increasing with, coming reports not only after the infection but also after vaccination. So a whole lot of inflammation is going on in the eye, and since now we have a few minutes left before we conclude the session, I would request Dr. Biswas sir to give some tips and remarks on the topics that we did not have coverage for discussion, like HIV, uveitis, toxoplasmosis, masquerades, and COVID. And then I request Dr. Ratinam to make her concluding remarks on the entire session. So, Dr. JB,
This is
sir,
a wonderful session. This was a wonderful session. I have got very little to react, comment, and what I have just wanted to tell you that the COVID is going to be is going to come as a
Sir, we don't see you, sir. Your camera is not focusing you.
Okay.
Please.
Move back. Can you see me now?
Yeah.
Can you come in the center?
Thank you. We want to see you, sir.
Okay. So we have just been seeing so much time. So that I think is that also one of the important thing is that you may make a phenotype diagnosis and you can start the treatment. What I do is the typical lesions. And if it's not typical lesions, you think about HIV infections. That's one of the things. Toxo doesn't require the laboratory test to start with. It can be supportive only or rule out a toxoplasma to some extent. And then regarding the syphilis, there is a neurosyphilis. It should be all syphilis cases should be taken as a neurosyphilis. CSF tap should be done in all cases of ocular syphilis, which I feel. And then viral retinitis, I would like to say that it's a real emergency in uveitis. So this uveitis, there is a very few emergency cases there except macular serpiginous choroiditis. But you need to react very fast in acute retinal necrosis because the reason is that they can go for retinal detachment quite quickly and vitritis and all these problems. And lastly, but the COVID infections, that not only that Candida, you can get Aspergillus infection, the fungus, we have seen the cases, and COVID vaccination, post-vaccination, we are seeing a lot of uveitis cases. I have seen few days back an intermediate uveitis. The patient did not have anything. Just after the vaccination, developed vitreous cells. And the treatment is not different, but you need to have a close watch. Taking the history of COVID, vaccination is quite important. That's all.
Thank you, sir. And over to you, ma'am, Dr. Ratinam.
Thank you, Manisha. Thank you, every one of you, for giving me a few minutes to talk to you. And it is a wonderful session. And thank you, DOS, for giving us one specialty day. We need not go all the way to America to have a uveitis specialty day. And it is wonderful to be in India and learn as much as we learned there. And the speakers, wonderful set of speakers, and all of them have real experience in the topics they talked. They never talked from textbook and they showed their cases and their experiences. That is a fantastic strength of Indian faculties. So I thank them all for the wonderful slides and the flow and the way they presented, and also for the topic selection by the organizers, because all the topics are extremely important. And Dr. Vishali, we need not say she's one of the topmost faculty having experience in tuberculosis. As though it was a very short topic, she covered everything. And every time we remember their algorithm, and the algorithm helps us a lot. And specifically the OCT findings and most of the publication from PGI Chandigarh has helped us to come to a stand to teach the world. And it is a wonderful talk and fantastic clinical pictures as well. And coming to Kalpana's talk, beautiful. The case of disc edema and SRF. Yes. With it is often mistaken. I have gone through this, and we ourselves have treated with steroids, and then we have lost the case, and now we are very, very cautious. And also the CNS viral infection, we have to be very careful, because at any time they can go for CNS virus complication. Especially we had a case of neonatal viral infection. Soon the patient had neonatal cerebral inflammation as well. And we didn't know where to refer the patient, because the neonatal setup outside government setup is extremely expensive. They cannot afford. Most of our patients cannot afford. And neonatal care in government hospital is good as far as the systemic condition is concerned, but ocular condition, they don't have any idea, and we cannot intervene between government doctors also. So we know how important it is to at least identify and affordable patients. We can immediately refer to a proper neonatologist. And Mudit talk syphilis, yes, it is a great masquerader, and his specific case, which mimicked Duchenne, multiple chorioretinal scars, beautifully ascending from center to top, was a wonderful case, because I might have thought that it is Duchenne, but it was properly diagnosed. As he says, in our clinic, every case we do TPHA, because the history is unreliable. No patient is going to say that he had exposure or she had exposure, because the history is not reliable at all. We don't rely on the history, but we do every case TPHA. And coming to Sudarshan's case, yes, he has vast experience in HIV. So in the whole session, the people who have handled the cases have talked. So he has wonderful slides where he has shown the acute cases, healed cases, and healed cases with treatment, and mimicking cases, a wonderful set of slides. And drug-induced night blindness is a new information which I have learned today, and I will be very, very cautious to elicit the information from these patients. Thank you, Sudarshan, for a new information. And Bala, yes, toxoplasmosis with centripetal healing. We have always seen this centripetal healing, but I have not used this term. So I really enjoyed. Yes, it is a centripetal healing that makes the scar more defined than the scar of ARN. I mean, we don't see, of course, in ARN. We see different scars like syphilis or tuberculosis, which are bigger scars, whereas in toxoplasmosis, it is smaller scars, and because of the centripetal healing. And he also talked about how other diseases can mimic toxoplasmosis. And one important information in this talk is toxoplasmosis and inadvertently treated with a steroid, periocular steroid or intravitreal steroid, can lead on to toxoplasma endophthalmitis. We have to be extremely cautious in such situation. We should not miss out toxoplasmosis. Without antitoxoplasma treatment, we should not give steroid, and that is very, very important. Manisha, wonderful coverage of masquerade syndromes. Yes, we do have retinoblastoma often, and as you have rightly pointed out, the moment we focus in the slit lamp, the picture is so typical. We always think of retinoblastoma or neuroretinoblastoma. Then also coming to the lymphoma, it is very easy. The sheets of lymphocytes, lymphoblastoma cells seen in the vitreous like intermediate uveitis in an elderly patient always make us think of CNS lymphoma associated with ocular lymphoma or ocular lymphoma alone. Padma, yes, COVID-19, we have seen quite a lot of cases of episcleritis, even before the vaccination. Once the first pandemic started coming, the clinic started receiving episcleritis quite often. So maybe it is because of vaccination, or maybe the community is getting exposed to the antigen. The episcleritis, nodular scleritis is so common. And also many of the patients came with HLA-B27, old patients as well as new patients. Number has increased. One of the youngsters can collect COVID positive cases who were admitted in the hospital and do HLA typing, and it may indicate that HLA-B27 patients are more prone for COVID. That may form one important hypothesis. Any one of you can take this hypothesis and do the research. And also one important thing in Vishali's lecture, I wanted to add one point. Because the government has changed the regimen from 4 drugs to 2 months and 2 drugs 4 months to, the government has changed now to 4 drugs 2 months and 3 drugs, ethambutol, for 6 months altogether. 3 drugs for 4 more months. So ethambutol 6 months has increased the number of optic neuropathy. So any one of the juniors now can take up a thesis or research to see how much it has increased, and we can address to the government if there is a real increase proven by a study, double-blind study or a study, then we can recommend that this is risky. Altogether, all the talks were really wonderful and many, many new things to learn. Thank you. Thank you for the opportunity.
Thank you.
On behalf of Delhi Ophthalmological Society, we would like to thank Uveitic Society of India and all the speakers. Excellent selection of topics, excellent talks, and we enjoyed the session thoroughly. Dr. Namrata ma'am.
Yeah, I've already thanked them for their, precious time and their contributions. And I think uveitis, I mean, it was like ma'am said very well, Dr. Ratnam, that the best part is that people have their own cases, and the amount of clinical material that is present in India is comparable to, none. And basically that was being shown, and that was being highlighted, and that was being showcased. So I would look forward to the cooperation from Uveitis Society of India similarly for future platforms as well. And thank you so much, everybody. Thank you. Dr. Biswas sir, very nice to see you.
Thank you.
And very pertinent remarks.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you, Rima, for nicely coordinating.
Thank you, Rima. Thank you, Rima. Wonderful coordination.
Thank you, ma'am.
Yeah. Bye, ma'am.
Bye.
Thank you.
Bye, ma'am.
Bye, ma'am. Bye, everyone.
Thank you, DOS, and thank you, USI.
Thank you, Rima. Thank you, Manisha. Wonderful session.
Thank you. Bye.